Well, everybody is much better behaved this morning, or maybe tired after last night. But welcome back to the second day of the oscillometry seminar. We're starting dead on time, so we're just going to take a minute. For those of you who are not veterans to the seminar,
Not veteran.
Not veteran.
Not veteran.
nobody?
You've been there before?
I can't read.
No, okay, so.
Oh, I'm not a PDF. Or llama.
Oh.
Any look at his t-shirt.
T-shirt.
Say it out.
Oh,
Awesome.
Charlie, say it out loud, Greg.
Awesome llama.
Oh.
That is really.
Okay, so
Everybody have psychiatry.
okay, so we're in the same place as yesterday. Know that all of these sessions are being recorded, and so you can view them offline later. And folks online tuning in late or on other days, they will be available hopefully within the next month, depending on my vacation schedule. Again, thank you to the industrial partners that made the event possible, and we hope that you're motivated to continue partnering with us into the future as we move the field forward. And I think everybody will agree that last night was a lot of fun. I hope to see over the coming 12 to 18 months papers in the literature that are a result of last night's supper, so I can justify to industry why they should continue funding, and importantly to us, why we should continue having fun. And again, thank you to the team of people, students, the McGill faculty, the MUHC RI, and the industrial partners for making it happen. So with that, I'm going to hand the podium over to Larry, who's going to pick up where we left off on this schedule of 31 programs. And Larry has strict instructions to stay on time. I can't believe we made it to the minute yesterday. We'll see how we do today. Paul, how are you? Why don't you turn on your mic and say hi to everybody, because we got you full screen here. Oh, you're still muted. Anyway, we'll talk to you later. Jump into the discussion. So, put this down for you, and you want to do first, go ahead. Okay. There, and here's Oli, and we go here. And do we have it a full screen here? Yeah.
Yeah. Is it online?
Are we, those of you monitoring online, are we visible online?
Yes.
Good.
Okay, thanks so much. So let me introduce someone who absolutely needs no introduction. Zoltán Hantas from University of Zagreb in Hungary, who's going to talk to us about intra-breath oscillometry. And to be honest, it's thanks to this whole area of intra-breath has come into development and has great opportunities to go further. Okay. There, take it away.
Good morning. First, I thank everyone for this and 10th organization. I'm most pleased and thanks for the support for me to come. I start with the provocative and I would say only ambition with title or I would be happy to have anything to disclose, so it's in the brackets. So the aims of our study were use follow the tidal change in impedance during the breathing, and present it in the form of the intra-breath impedance vector. And this is very exciting stuff, at least for me. And I think that this detailed description of lung mechanics during quiet, non-maneuver type breathing could give us a very delicate, very detailed description what happens during breathing into the lungs or the total respiratory system. And we made a preliminary study in three subgroups of subjects, healthy ILD, asthma, and COPD subjects, and wanted to see how these interval changes differ between groups. And to make you excited by this adventure, I hope that you will like it, despite my limitations in presentation and unexpected errors in my slides. You will be supportive in the future. So these four groups were recruited from Toronto and Montreal. Toronto from the University of Toronto University Health Network. Changwai and Joyce are here. And from Montreal, Aaron is here, who is responsible for probably 1/3 of these subjects, and 100% of the COPD, and 100% on the asthma group. And the ILD, which happens to be the largest group in this comparison, is from Toronto, and it's a follow-up study. The data I will present are from the first visit of this population. So we use the ThermoFlow C100, but only the 10 Hertz single frequency interval modality was used in this study. The pressure flow signals were exported and processed with a homemade software at my place. To give you an idea how the impedance changes during breathing, I will probably ask you to concentrate on the COPD group, which shows resistance versus volume. This is end expiration, this is end inspiration. And basically nothing much happens during breathing in resistance, just a drop in resistance between the end expiratory and inspiratory parts. However, here we have an inspiratory part in red and an expiratory part. This pattern is the tidal expiratory flow limitation, which was physiologically validated as an oscillometry measure more than almost 2 decades ago by Raphael and his co-authors. We are looking for the zero flow measurements, the end expiration and end inspiration, and these will present us a vector in the impedance plane. This is a complex plane mathematically, but should be accepted and loved by all respiratory physiologists and pulmonologists, I hope. So at the instant of the end expiration, the FRC level, our impedance value consists of this resistance and this reactance value. And with a simple tidal inspiration, we arrive at a different point, which is typically at a lower resistance and a higher reactance. It's not exclusively for one group, some differences are changing. So normally, the changes are interpreted in either in terms of resistance values, and people concentrate on the resistance changes, or especially in asthma research, they prefer to look at the reactance, how it changes, not during a tidal breathing, but a deep inspiration, deep expiration, and things like that. This is a combination of the two, because both change during breathing or during bronchoactive investigations. And we selected the description of impedance now in terms of impedance magnitude, which is the length of this arrow, and the phase angle, which is calculated from this point on. And we have a color code representing the greens are the more vertical, that's reactance changes dominate. The blue are the more horizontal. We hardly see the opposite direction. In this point, there is no change in reactance, only in resistance. So let's show you how the healthy population impedance vectors look like. You have every color here. The scale is adapted to the whole population. So we have low impedance values, low reactance values, the lowest reactance being probably 2.5, but it is just still in the healthy population. And you have every color, every direction, and too many arrows here to see the proportion of them. If you look at the histograms of the impedance magnitude, the maximum is somewhere here in 0.3. In as the impedance vector length, and in terms of phase angle, it's typically about 190. It's almost horizontal value. The next group is the asthma, where in addition to this very colored, very healthy-like group, you have lots of green, which means that huge improvement is in reactance and improvement in resistance as well. There are funny few exceptions, but the overall picture is that our histogram is very wide. So we have I have to improve. Here we have much wider scale in the phase angles. So if we superimpose the histograms of the asthma population onto the healthy, there's a great deal of overlapping in the phase angle. Healthy having more higher angle values, and there's a distinct low angle, which is more vertical. So this is the obstructive type. COPD is similar, apart from the fact that I copied the wrong here, because COPD hardly has anything here. It's all green, basically. I'm sorry for that. My slides crashed this morning. So here we have 120 degree, so more vertical behavior. And if you compare it with the healthy, there is overlapping both in magnitude and in phase angle. I prefer the last one. It's most spectacular. Visually, it's more much nicer, but they are very distinct. And last, the IRD, which gives us new colors, this opposite change, where resistance decreases and reactance goes down, but not exclusively. We see a lot of greens here, which are basically expressive flow limited. So they don't fit in the general scope. If you compare the phase angle of the IRD population with the healthy, we can see that healthy is shifted towards, but we have super healthies here from the IRDs, and they also have a long leg with obstructive type. We were very much concerned why the IRD population is so heterogeneous. And the first idea was that, yes, because it consists of major subclasses like IPF, hypersensitive pneumonitis, and a combination of emphysema and pulmonary fibrosis. But despite the fact that the population size in the subgroups is not the same, we can see that basically also subgroups are as heterogeneous than the IRD was. So it's something very provocative idea about whether, from a functional point of view, these groups were properly diagnosed. So we may conclude that the simultaneous presentation of the resistive and reactive changes during tidal breathing offer a quite detailed approach to describe the mechanics during quiet breathing normal tidal range. And it suggests that it might be very useful to involve in the routine oscillometry measurements as part of the routine PFT measurements, and may open a spec to establish a new functional phenotyping of major disease groups and probably the subgroups. And the last remark is that some phenotypes definitions are associated with imaging information. It would be extremely useful if, for instance, CT measurements are made at the tidal range at FRC and without total inspiration, but everything is normalized in a functional point of view. So thank you for your attention and your patience.
Great. Thank you so much, Zoe. Stop sharing. Before I totally open it up to the audience,
Encourage the people online.
I will,
Their
if-
cameras
when
on
I-
so they can see them. They're all off.
right, when when it's in
No,
on the
but you have to tell
participant.
them, folks on the internet, please turn on your cameras so we can see you and have a discussion.
Okay, but before we start, Zoe, so if you compared your asthma versus COPD, do you see a difference?
Yes, I'm very sorry. So 5 of my slides collapsed by copying this morning into the pen drive, and one was not properly connected. So the COPD vectors were basically all green. No, they just went up.
And if with bronchodilators, do you see what type of change do you see? Do you see a shift toward?
We haven't tested it, but the next speaker will probably tell you. He's a pediatric physician.
Okay. Charlie.
Solly, it really is. The vectors you're presenting, they're really looking at in the inspiration and expiration.
The other way around.
Well,
It
whatever,
starts the beating from the past. So an expiration and inspire.
but you're not really capturing sort of hysteresis of.
This is now simplified because we are rather interested in loops because they describe all the changes.
Yeah, I know, that's why.
So it's not obvious from the COPD vectors that they are all But if you look at the,
No, I get that. That's why I'm trying to understand how the plots you showed capture the big, but that's
Yeah.
something we talk about. Offline. The ILD.
Please put your cameras on if you're
When we
online.
started building the ILD cohort in Denver, all the lung function tests were done in the lab. And I was really struck with how heterogeneous ILD patients are. There's very few of them with pure restrictive stuff like you see in the tech. They have a lot of airways disease. So, and then one of the things that the ILD, correct me, there's an expert here in the room knows better than I do. You know, like NSIP is very different than some of the other ones. And sensitivity pneumonitis, as you've already alluded, is probably more like asthma. And,
they are
So it's a-
also equally mixed.
And I think this is why every 10 years, the ILD guys get together and they totally redefine what they're doing. So I think that's an interesting group to help ease those sorts. Yeah. Nice.
This is my favorite at the
Yeah.
moment. So it's good.
Time for one more. Go ahead.
It's more a clinical question and relates to the groups that contributed the patients to this. But asthma on a bad day looks like COPD. And in the later stages, many asthmatics develop fixed obstruction. So when you are talking about asthma, COPD, are you talking about ample asthmatics that do not have fixed obstruction? That is a group. So I just want to make sure. And in clinical medicine, we often have that problem. You know, when we face a patient with obstructive lung disease, particularly if they are not very young or, you know, very towards the end of, you know, the later decades, that, you know, what is it? And more so if they are light smokers or non-smokers. But so are we talking about fixed obstruction when we're talking about COPD and included from asthma? How these groups are characterized?
We have 1 minute left.
Yeah.
And Paul, I'll give you a last shot. Jeff, you have a question. Did you want to answer?
Well, actually, I didn't have the time to emphasize how heterogeneous the aspect reports. So this is a reason not be able to tell more because they've well-controlled asthmas and not well-controlled. They took medicine before the visit or not. So that reflects.
A mixed community practice asthmatics. So it's a number of them are on biologics and others sort of see me once or twice a year. Action plans are active, so they're very spectrum.
Okay, so I'm going to give the last question to Paul Robinson.
Hi, everyone. Hopefully you can hear me.
Yeah.
Zolli, I think it's really interesting work. And I really like the fact that it reflects both the changes happening in resistance and reactance. My question to you is, the challenge in this space when you're trying to introduce a new approach or a new kind of indices is being able to show that it's superior or it's kind of value adding. So what kind of data do you think is now needed to be able to show the utility of this approach compared to conventional approaches?
Well, first of all, try it in children. In 1 minute, probably.
We're going to hear about that.
And increase the number of these populations because we should have access to both COPD and asthma patients, and in particular healthy. IRD is fine, but we are following them. It's very interesting to see the changes in the latter group from one test to another, whether they change the direction or therapy modifies the introvert vector properties. So first of all, I would emphasize the large groups involved and looking desperately for CTs which are not at PLC and Supa is all right, so we can't have, but somewhere in the tidal range, that would
Right.
extremely.
Great. Okay.
So Paul, just quickly, my students are stuttering because I know I'm gonna dump more work on them. Basically, we're gonna take miasmatics and COPDs from that and group them by vector groups. And then we can look back at their clinical courses because we have their time course going back a decade. And we can also then follow them forward and see if there's anything that is interesting when you divide them up by the bin that Joe Tully has suggested.
Makes that.
And I suspect the challenge will be in ILD because it's so heterogeneous that you may need to be looking in a group that's a little bit more homogeneous to kind of be able to clearly define the additional signal that it provides, and then but I think it's a really interesting approach. So well done, Zolly.
Okay. Thanks so much. So next speaker is Matthew Wong from University of Queensland. So Matthew, no pressure here because we're going to build up for vectors and maybe looking at something cleaner, purer population is pediatric asthma. So do I just click on?
Let him go. If you're unsure.
Yeah. Okay, take it away.
Okay. Hello, everyone. Can you hear me?
Yes.
I'll see if I can share my screen here. How do I share my screen?
Bottom center. No, it's going out of the
Trying to just find out the screen share.
Often at the bottom.
Oh, yeah, it's a bottom. Sorry, it's at the bottom bar.
Button at the bottom.
Okay, yeah. Starting my slideshow. Hold on. Share this. Okay, can everyone see my screen? My title screen? Great. Okay. Good morning to all in Canada. My name is Matthew Wong, and thank you for the opportunity to speak about some of my research. And today I'll be presenting some data on pre and post bronchodilator impedance vectors in a wheezy preschool population. And I have no relevant disclosures. All right, so diagnosing preschool asthma is challenging. Wheezing phenotypes have poor predictive value, and a recent GINA update on preschool asthma states that lung function testing, bronchoprovocation testing, and other physiological tests don't have a major role in the diagnosis of asthma at this age. And I think it's because the clinical utility of lung function, such as bronchodilator response testing, is unclear in younger children. So today, my aim is to present data on evaluating tidal and bronchodilator response impedance vectors using intrabreath oscillometry, and this is involving healthy and wheezy 3 to 6 year olds. So this was a prospective observational longitudinal cohort study. There's healthy children recruited from the community and wheezy children recruited from the emergency department. The wheezy children were followed over 12 months with various lung function measurements at the timeframes shown there. And bronchodilator response testing was done when they were asymptomatic at the 3, 6 week, 6 month, and 12-month periods. Healthy children had bronchodilator response testing when they were asymptomatic at separate visits, 6 weeks apart. So at one visit, they had a bronchodilator response, and other visit, they had placebo response testing, and we randomized the order of this. We used a single 10 hertz frequency and a research modality of the Tremoflow C100. This table shows key study population characteristics. There were 53 healthy children and 104 wheezy children who provided acceptable oscillometry measurements for analysis. There were no significant group differences in terms of females' age, weight, or height. 65% of the wheezing cohort had a positive skin prick test. A bit of overlap on what Zoli's already helpfully introduced. So here are two forms of intrabreath impedance vectors shown. And the color coding is, in my study here, is more simplistic. Rather than a spectrum of colors, I've just got 4 colors in quadrants using the same sort of angular reference with 0 at due east that Zoli had introduced. So here, green colored are tidal impedance vectors. So this shows within subject impedance changes in the direction of end expiration to end inspiration. And it illustrates the volume dependence of impedance during tidal breathing for each individual subject. And for this example, it's green because this phase angle phi is 150 degrees, according to this legend. Bronchodilate response vectors show within subject impedance changes following inhaled bronchodilators. And these vectors have a magnitude and a direction of change as well, which are specified by this angle phi ZEE. We're focusing on end expiratory impedance for the bronchodilator response because that's where we would expect the greatest changes to occur. This particular vector has an angle of 110 degrees. If the angle was 135 degrees, then there would be an equal change in resistance and reactance. Here, tidal impedance changes in healthy children are predominantly characterized by decreased resistance during inspiration, which makes the vectors mostly green, where there's more horizontal change in their impedance. A green vector indicates a proportionally greater change in resistance than in reactance. And this can be explained by homogeneous or uniform dilatation of the airways, which predominate the impedance change. And that would be what's expected in healthy children. Now, asymptomatic children who have a history of recurrent wheezing also have a predominantly tidal change in resistance. So most of them are green, but some have larger changes in reactance. And you can see this illustrated with these blue vectors appearing. A blue vector indicates a proportionally greater change in reactance than in resistance. And this suggests increased time constant differences between lung regions. This final panel shows acutely wheezy children in hospital. So these are children who were measured in the emergency department, who have been given any number of bronchodilators, steroids, who are acutely unwell. And you can see there's even more blue vectors. And qualitatively, the vector magnitudes become larger when the impedance is abnormal. So here we used generalized linear mixed models with subject level random intercepts, and we adjusted for the height of the subjects to evaluate the tidal vector's ability to discriminate healthy from children with acute wheezing. And basically what we found was that tidal vector magnitude was a strong discriminator of healthy and acutely wheezy children. And this is despite receiving a lot of bronchodilators in emergency department. Okay, so this is basically acutely wheezy child, which you can diagnose with a stethoscope and clinical exam. In this figure, we have tidal vectors which are compared here in panel A before bronchodilator and B post bronchodilator. And in the healthy cohort, you can see that there's little change in their intrabreath impedance, pretty much clustered in a similar pattern. When asymptomatic children with a history of wheezing have bronchodilators, there's 2 things that are observed. The magnitude of the tidal vectors decreases. So pre-bronchodilator, we've got some blue vectors here and quite large vector magnitudes. But then post-bronchodilator, it looks very similar to the healthy cohort. And most of the blue vectors disappear, which suggests an improvement in end expiratory reactance. Here, placebo response and expiratory impedance vectors in healthy children from the placebo testing illustrate the within session measurement variability. When these healthy children have bronchodilator, most have improvements in both resistance and reactance. And the healthy children, again, have predominantly green vectors, so changes in resistance. So bronchodilator response in healthy children is predominantly an improvement in resistance where the bronchodilators act to improve the tracheobronchial tree dilatation. In asymptomatic preschoolers with a history of wheezing, we have a lot more blue bronchodilator response vectors, particularly those with a more negative reactance. Post-bronchodilator resistance and reactance values are very similar to those in the healthy group. So some asymptomatic children with wheezing have reversible ventilation inhomogeneity in the peripheral airways in accordance with the classical concept of change in dynamic compliance, which was described by Otis. Similar methods were used to evaluate the discrimination of healthy from asymptomatic children with a history of wheezing for tidal vector outcomes, bronchodilator response outcomes, and also relative bronchodilator response for end-expiratory resistance and end-expiratory impedance. And what we found was that tidal vectors outperformed BDR vectors and the relative bronchodilator response variables in discriminating healthy from asymptomatic children with previous wheezing. And it's important to note that these are children who, for the study, were measured when they were at least 3 weeks away from any respiratory illness. So if they were unwell with the wheeze or had an upper respiratory tract infection, we rescheduled the visit and they came back when they were at least 3 weeks symptom-free. So a normal physical examination, and this is the discriminating capability of the tidal vectors. We apply these same methods to just the wheezy cohort to discriminate well-controlled versus poorly controlled symptoms. So we used childhood asthma control test scores as a clinical anchor. And in this model, we adjusted for the use of inhaled corticosteroids as a fixed effect and also subject-level random intercepts with the repeated measures data. And here, the bronchodilator response vector angle and relative BDR for an expiratory impedance provided good discrimination. I think I'm nearing end of time, but finally, we looked at the agreement between these tidal and bronchodilator response vectors using Spearman correlation. And what we found is that when we overlap them, there's a few observations here. So the tidal vectors are in orange and the bronchodilator response vectors are in purple, and they have the same starting point, but then they deviate in terms of their magnitude and phase angle. In the healthy children here on the left, we can see that there's a weak correlation between the vector magnitude and angle based on the Spearman correlation, the rho values. And on the right, we can see that the vector magnitudes and angles were moderately correlated. And you can see these purple vectors have a bit of a steeper angle compared to the orange tidal vectors. So in conclusion, this data is my first description of interbreath oscillometry bronchodilator response vectors in a preschool population, and also the use of bronchodilator response impedance vectors, which are really useful to show within subject changes in resistance and reactance. We have bronchodilator response vectors, which are better than traditional BDR outcomes, so just relative BDR, at discriminating healthy from asymptomatic children with history of recurrent wheezing. And the tidal vectors are better than the bronchodilator response vectors. And this is really interesting because the tidal vectors may be able to detect a mechanical signature that's associated with early peripheral airway disease. And they may be more sensitive because they involve a baseline measurement rather than having to deal with pre and post bronchodilator test repeatability and measurement error. However, bronchodilator response indices are still useful for monitoring symptom control and for identifying children who have reversible airways disease. Thank you.
Great. Thanks so much, Matthew. Take away, Jeff.
Oh, thank you very much. That was really impressive. So I'm struck that within tidal breathing, which is just a small part of our total range of our mechanics of the lung, that we have such discriminatory power, like compared to our standard before and after bronchodilator measure, being reactive. And that angle is actually a really strong discriminator all by itself. And I'm recalling Vanessa Kelly's work that showed that if I do oscillometry at true lung volumes, I have a huge discriminatory power in how there's a critical change in reactance as I go down in volume. In asthma, that's not there now. So I wonder if we altered the maneuver to explore more volume. You do tidal volume to do this, but then at the end, you decide to do a large extent, just to explore the reactive state, especially in those people or children who are not symptomatic, but are coming in because they have symptoms at another time, something like that. You might find a very early detective way of basically looking at early disease, because during cold breathing, maybe you're not sensing it as strongly, but just do it a little bit more, go to a little lower volume, little higher volume. I don't want to get rid of the fact of whatever magnitude you're doing with tidal breathing, but if angle is really important, why not do a big breath to get a really good look at the angle of the vector?
Yeah, thank you. That's an excellent point. Yeah, so these were only done with quiet tidal breathing, but yeah, it would be really interesting to see the volume dependence of impedance with a big breath. Yeah.
Okay, well, I'm going to ask a question. I've gotten very interested in the risk of airway remodeling, which is an early phenomenon in children, especially those who have wheezing with viruses and have atopy. And one of the problems is, so how do we know that airway remodeling is going on without doing a biopsy? And I'm just wondering, if you follow these kids out who now are asymptomatic but a history of wheezing, if you take them out longer, do they truly become normal, or do they still stay abnormal? And would that be an indication possibly of airway remodeling? Or is it something we could use to give it as an indication?
Yeah, great question. I have data on all of them because I think all of the cohort have now reached the age of 6. And so I think just with my selection criteria, I've selected kids with quite, quite a lot of symptoms. They had to have at least 3 episodes of wheezing in the last 12 months and have acute severe wheezing presenting to an emergency department. So I think 75% of my cohort here, of the wheezy cohort, actually would meet a definition of asthma past 6 years of age. So they're still wheezing, still needing to take bronchodilators. And there is plans to follow up this cohort within our group between the ages of 7 and 10 to have it further longitudinal data. So it'd be really interesting to compare their tidal vectors at baseline to see whether they become more abnormal, and whether there's some sensitivity to there to detect peripheral airway disease.
Okay, I'll leave the last question to Paul.
I was just going to add a comment to Jeff's point about kind of varying volume. With Vanessa's work, I'd always thought that essentially what she was showing was that kind of onset of airway closure that kind of happens in these young kids. The challenge is that you can get them to do bigger breaths, but it becomes quite challenging to try and standardize the way kids do it because they all do it to different degrees. And I think what's really interesting in Matt's work is that we're seeing an apparent signal within just normal breathing. And if Matt can then follow the cohort later on and actually show what that relates to prognostically, that may be good enough. And I think that's the key thing is kind of understanding what kind of signal we can see early on that relates to later outcomes, because that's a true thing we've really lacked in preschool wheeze, in preschool asthma, is we've lacked something that really tells us about where they're going to end up to the point we can then intervene and try and modify progression over time.
Great.
Time for one more.
Oh, one more question. Yeah, one quick one.
Hi, Matthew. My name is Daniel Gemkin. I'm from the University of Toronto, working with Dr. Chung Wei Chow. Thanks for presenting this excellent work. I was wondering if the absolute magnitude vector and the angle vector in combination if they provide complementary and additive value to each other instead of implementing them in separate models. So, do they give each other more information essentially?
Yeah, that's a great question. I did play around with like different weighted models and weighing the variables differently. And I think the problem I ran into was because it is still a small sample size. I only had 50 healthy kids and 70 to 80 kids who finished the entire 12-month follow-up. I ran into some problems with the models. But it is something I did briefly look at whether, yeah, a combination of magnitude angle would provide even more sensitivity in terms of, yeah, discriminating groups. So I haven't yet fully explored that, but that's a good thought.
Great. Well, thanks again, Matthew.
Thank you.
Okay, so next speaker is Sarah Nemeth, who just have to be able to get out of this all the
Escape the window button.
oh, there we go. Fine. Okay.
I don't think we're sharing yet.
Right. So I have to, I guess, escape from here. Zoom.
You hit the window where Matthew still is, you can make that go big.
Okay.
Up there, and you see the two arrows?
Yeah. Okay. Then go, where's,
So it's,
oh, there's Sharon. Telling you there's Sharon. Okay. There you go. Good. All right. So the further technical mishap. Take away Sarah.
clear the arrow.
Oh, yeah. The arrows around.
The arrow. But let's give it.
So good morning, everyone. My name is Sharon Németh, and I'm a computer science graduate student in the University of Szeged. And today my presentation will have two parts. First, I will talk about intrabed loop processing, and then I will talk about some pattern inheritance in children's measurement. So the data that I will be working with is part of the CEPAS cohort, and it is a subset of it. So it's made up with 160 children who were measured with intrabed oscillometry at both the age of 3 and the age of 8. So these children at the age of 3 had a really heterogeneous respiratory state. So there were some children who had a history of wheezing, and also some of them who were diagnosed with asthma. So the main limitation of my current study is that I didn't use these respiratory labels. So I will just give you some general insights, but it is also the main possibility to continue this research in the future. So the 3-year-old measurements were already evaluated, and it was found that the respiratory resistance corresponds quite well with these early age respiratory diseases. The measurements were made with the Tremoflow C100 device, and it was used with the intrabed modality. So as you know, a 10 Hz tracking signal was superimposed on the children's breathing, and that caused flow and pressure changes that were tracked with the specific sensors. And I started with the research with these raw sensor data. So first, I have to calculate the respiratory impedance at 10 Hz using my custom pipeline. I won't be going into detail for here because I think most of you know very well how it goes, but the important thing is that I got the 10 Hz respiratory impedance, and when we are talking about intrabed oscillometry, then we usually like to visualize the data as intrabed loops, which means that we plot this impedance as a function of the changes of tidal flow and tidal volume. As here you can see the flow and the volume. And here is a little example of how intrabed loops form in time. The first challenge of the data set was the data cleaning, because as you know, real-world measurements contain a lot of artifacts, and it is especially true for children's measurement. And for that, I created a three-stage data cleaning pipeline. And here the first 3 column corresponds to the 3 stages. In the first row, you will see the input of each stage, and the highlighted loops are the outlier loops. And on the second row, you will see the visualization of the reasoning behind the outliers. So for the first stage, I tried to identify breath cycles that had measurement errors, such as peaks. So I did it by comparing the individual loops standard deviation to the measurement standard deviation. Then I moved on to identify breath cycles that were either too deep or too small. And I did that by looking at the flow over volume plot. And I just look at that plot as a data cloud of measurement points, and I try to identify sparse regions. I use different type of outlier detector algorithms for that. I generally found the local outlier factor to work the best. And this is kind of the outlier detection version of k-nearest neighbors algorithm. So you might be familiar with it. And then for stage 3, I did the exact same thing, except on the intrabed loops themselves. The reasoning behind that is that I try to identify unique trajectories. So when a loop has a unique shape in the whole measurement, that usually means that it is an outlier. And in the last column, you can see the clean data and also the outliers. So this was an example of health of an adult measurement, but for children, the data cleaning had to be a little bit more aggressive and had to be fine-tuned. So this is an example of a measurement. The first column shows the raw infrared loops. The second column shows the filtered one, and the third column shows the artificial median loop that we like to use for our research. I call it artificial because it is not a loop from the measurement itself. I create it by resampling all the breath cycles in the whole measurement, and I take the point-by-point median and create a new loop shape that we generally find really descriptive of the whole measurement. Here is another example, and it is just interesting because, as you can see, the number of breath cycles, I had to filter out more than what I left. And usually it's confusing for the computer when you are telling that the minority is the real data and the majority has to be filtered out. So going to the children's data itself, so the children are measured at age 3 and then at age 8. And over the span of these 5 years, we can expect that they have grown, so they have increased lung volumes, their breathing slowed down, and also the impedance values became lower. And this is what we can see on the histograms themselves. But then we looked at loop shape descriptors. So we went back to some spirogram descriptors because everyone knows them very well. So this is the ratio of the expiratory time to the total breathing cycle time. And we expected originally that it would stay the same throughout that 5 years. Because it reflects kind of the mechanics of the breathing cycle. And when we looked at the two data sets, we saw the histograms were really overlapping. And first, we were really happy for that, but then we plotted these values against each other. So the 3-year-old values against the 8-year-old values. And as you can see, we only found a random scatter. So the individual changes could not be quantified like this. And most of the loop shape descriptors give the same results. So I will just give you some examples for that. And here you can see what we really like to use in intrabat oscillometry is the loop areas. They do overlap, which is surprising because even the tidal volume changes and the impedance values change a lot, but still the changes cancel each other out. So the overall overall values is the same for the two data sets, but we couldn't find an individual connection between the data. Lastly, what we looked at is the changes of delta R based on the end expiratory resistance, because Zoli has been experimenting with this plot for some cohort, and he did found some connection. And for us, it was a little bit surprising that when we interpolated a line on it, the slope was a little bit different. So here, at least, we found something different. And the last thing that I want to talk about is correlating the trajectories themselves. So on the x-axis, you can see the 3-year-old and the 8-year-old resistance correlated against each other, and the correlation efficient is plotted on the x-axis, and for the reactance, it is the y-axis. And here you can see on the top right corner, a subset of children who have really high correlation in both reactance and resistance. And my hypothesis is that these are the children who were healthy at age 3 and at age 8, so they could keep some of their loop characteristics throughout these 5 years. But if they had any type of respiratory problems, those problems have a higher effect on the loop shape than the inheritance pattern. But obviously, we have to confirm it with the labels. So I've done some unlabeled clustering on the intrabat changes and plotted the results over it. So I hope that we can get to these results. But the truth can be the exact opposite, because when we are looking at one measurement, we can see that the healthy patient have a higher inter-measurement variability, because the changes are small but relatively big to them. And when we look at a patient with COPD, he will go through the same trajectory again and again. So lastly, I would like to just show some examples that try to justify my hypothesis. So on the left side, you can see the 3 years old intrabat loops, and on the other side, the 8-year-old. So what I would like you to look at is the flow dependence of the expiration that stayed the same after 5 years. And for me, what was really surprising is this crossing in the reactance that happens at the same flow after 5 years. So I think this is a really unique loop shape that stayed the same after 5 years. Here is another example of two similar patterns. And just to be true to the data set, here is an example where the two patterns could not be matched visually. So here you can see that the expiratory dependence of the resistance does change. It's just actually the axis that distort these changes, but what is very obvious that the loop areas in the volume loops change a lot. So I would like to thank everyone who helped me with this research, and I hope we can still work on it and look at the clinical labels to justify everything that we found. And thank you all for your attention.
Thanks, Sally.
If I could make just a comment, thank you, Charlotte, for the wonderful characterization, methodology and analysis. It's a tremendous amount of work. The comment is that the CEPACH cohort is a birth cohort from Grenoble, France. So it's a single cohort that aims at looking at prenatal and early life exposures to environmental factors and how they affect child health in general, respiratory health. and the 8-year measurements are still ongoing. We're getting 10 hertz measurements. We already got the 10 hertz measurements, single frequency at 3 years. And now the measurements are still ongoing. Expected by September, October, we'll have all the kids measured and something like a close to 90% follow-up rate, which is exceptional. So what I think is unique here is that you can, based on your blind analysis, and we could trace back to see which kids had history of wheezing, asthma, or lower respiratory tract infection, because that data will be available at some point. And Shara didn't have access to those. So the goal is to go trace that back. That's just that.
Thank you.
Comment.
Great.
Thank you. That was very interesting. Leonard Lundblad. Thank you. One thing I thought about, and that's sort of when I saw Paul Robinson's face here, the publications they did a few years ago, looking at kids that were doing measurements at home daily and who had asthma, and one could see that they trended, got worse and worse until they exacerbated. That's kind of, not surprising. But what surprised, I guess, some of us at least, was that one day you could be looking pretty bad, the next day you could look really good, and vice versa, right? So a single measurement might not be very predictive, if I remember the data correctly. So I wonder, what is the reproducibility, or have you any idea how these children look from one day to another?
I don't have any data for that, and I think that
Yeah.
wasn't measured.
No,
But-
it's a single visit.
This is the
Single visit. And already the kids go through a bunch of measurements. So it's very difficult to have them
Of course, yes.
another day. So, yeah.
But I agree with that, about the day-to-day reliability is really high, but usually for children with respiratory diseases, they tend to go in the same introvert trajectories. So I think this might be still really descriptive of them, but it does need some further analysis.
I guess it's sort of what I'm going after is, would this kind of tracking be more sensitive to underlying permanent issues rather than looking at what is
Probably,
essentially
yes.
just the regular oscillometry parameters?
Well, we have to see that.
Yeah.
Paul,
Hi, I mean, just building on the last point is others have shown kind of variability in kind of different time series. So you can see variability across breaths within a single recording, or you could potentially be seeing variability between test sessions within the same day or across days. So one of the questions I had just for this approach is the challenge is you're trying to separate out signal from noise, and you're hoping that your filtering is taking out the noise and leaving in the signal. And some of the nice examples you showed, it's very clear where you're taking out the noise. And I just wonder whether, how you're approaching that kind of sweet spot of making sure you're not losing the signal. So the variability that happens even within a single recording across breaths may create differing patterns between breaths, and that may be something you filter out when actually that's the most important part.
Yes, thank you. That's an excellent question, and I've been struggling with this. I have some strict limits that I need to keep at least 3 breath cycles, and I do lose information. So I do lose a lot of good breath cycles, especially with this aggressive filtering. But I'm always making sure that I leave at least 3 pieces, and after that I usually just compress them into one median loop. So the 3 breath cycles are descriptive themselves, but other than that, I just went through the whole population and I looked at the before and after results and confirmed if it was correct. And if it wasn't correct, I would have manually adjusted the results.
Great. Well, thanks so much, Aaron.
Thank you.
All right, so our next speaker is actually Ron and my student, Mohammed Bahad, who's been working on cystic fibrosis in a healthy pediatric or in a pediatric cohort that we have. So. Yeah. Oh, okay.
And then on the double arrow, yeah.
Okay.
At the bottom.
Yeah. Shame. All right.
Yeah, thank you, Dr. Larry. So thank you and good morning, everybody. So my project is the type monitoring small airways and cystic fibrosis toward more sensitive tool. So first, allow me to talk about the effect of the CFTR, cystic fibrosis transmembrane regulator gene modulator therapy. This is a major success for the clinician, especially. So since the introduction of this therapy, we observe a sustained clinic improvement in the patient with cystic fibrosis, both in kids and adult. You see here the principal parameter of spirometry, the FEV1, is improving for in the majority of the patients with cystic fibrosis, more than 15% predicted when we compare to placebo. And on the right here, this is the data confirmed by the Canadian Cystic Fibrosis Registry when we found with the kids here more than the majority of the patients have more for the FEV1 80% in minimum. So and the 84% of the patient have more than 90% of the FEV1. It's mean close to this improving, the clinic improving, we are exposed to another problem is to find, because now we are limit the spirometry, we are exposed to the limit of a spirometry. That's why we are looking for other tools more sensitive than spirometry. So spirometry became, since this introduction of this medication, became less sensitive to detect the small airway dysfunction. This is the rationale of our study. So here to show you the different abnormalities in the early in the early of the beginning of the cystic fibrosis with this disease, and these abnormalities you see here that are not detected by spirometry. That's why we are now looking for more sensitive tool to detect these abnormalities in the beginning of the cystic fibrosis. You see here, especially the second subject, the FEV1, despite it has 100% predicted, but there is all abnormalities. He's a lot of abnormalities not detected by spirometry. And when we see the LCI here, we can detect. So LCI, we can say that the LCI is more sensitive than spirometry to detect the early small airway dysfunction. So the normal FEV1 doesn't exclude early structural lung disease or ventilation abnormalities in cystic fibrosis. Here only to show you also that we are also following with when the patient are receiving these modulators, the therapy. So the LCI, the lung clearance index, became the marker to follow the clinic with in these kids with cystic fibrosis, and the spirometry, it became always and the majority normal. We see here that's when we, for example, do the lung clearance index, we see that we can, it can become a marker, a good marker to follow the kids with the cystic fibrosis. Here we is decreasing with on the therapy. So the LCI detects only small airways abnormalities and is sensitive to clinical improvement following cystic fibrosis transmembrane modulator therapy. This to show you the difference between how to do the two tests, the lung clearance index versus oscillometry. The difference you see here, for the lung clearance index, the problem is it takes a long time, and the equipment is very expensive, and we take a lot of time to do this test. That's why this test is not present in the clinics. So they are right now only in the research institute. And that's why we say that oscillometry can replace the lung clearance index, because it's easy to do. You see here only 10 minutes, and the equipment it's less expensive than the lung clearance index. This only to show you, to give you an idea how to do the lung clearance index. So to take the quiet tidal breathing, and what's the lung clearance index? It's the wash breathing, the wash breathing, wash out, the wash out breathe in those. So this test is take in the normal breathing, and we calculate when the tracer gas concentration falls to 2.5% of its initial value. The initial value is 78%, the room air, and the lung clearance index is an index. So it's the cumulative expired volume divided by the functional residual capacity. And this to show you how we perform the LCI, and it's the washout to arrive to the target 2.5% of the gas of the beginning. And this is the new NDIS. So we talk about, this is the NDIS of the lung clearance index, which call it the extended lung clearance index. That means when we finish with the conventional multiple breath washout, the lung clearance index, when we arrive to the target 2.5%, when we arrive to this, we continue, we ask the patient to take a calm breathing for 3 or 5 breathing. And after that, we ask the patient to take a slow vital capacity. As you see here, this is the CT image. It's normal, and we see here this is the inspiratory, the volume, inspiration and expiration. And when here we ask at the end, I said at the end of the LCI, we ask the patient to aid the small vital capacity, and this is the small vital capacity here. The inspiration very, very slow, and the exhalation very, very slow. We see here there is no exhaling the gas. It's normal. But when we compare to the image where we have these abnormalities as the mucus plugging, and we at the end of the lung clearance index, we do this maneuver, which is called now extend lung clearance index. We will see here there is because the idea behind this technique is to dislodge the mucus plug, and to try to find the lung unit index. They are not evaluated by the lung clearance index, and that to give us the trapped gas, which was trapped in some lung units. So the LCI short extension reveals hidden ventilation abnormalities beyond conventional LCI. So a deep breath opens closed area due to mucus plug resulting in excess inhaled nitrogen. And this is a strong correlation with mucus plugging with the lung clearance index than the lung clearance index, the conventional lung clearance index, and we can discuss at the end of my presentation. This is only to show you the formula. It's a little complicated, the formula, how to calculate the LCI lung extension. And this is how to calculate the unit, the underventilated lung unit. That means the LCI short extension minus LCI, and we give us this parameter. We can discuss at the end of my presentation. This is, I arrived, so my hypothesis is only to compare this three tools, spirometry, oscillometry, lung clearance index and lung clearance index short extension, and we recruit the patient, all our patient, my patient right now, I did 17 patient to the criteria for the recruitment to have the FEV1 normal, that means more than 80%, that means the normal spirometry. And here, this only to show you the biometric parameters, and all our patients here are clinically stable, and no parametric statistical methods were used for the data analysis. And this, when we compare to the spirometry, the lung clearance index to spirometry, I found 4 abnormal for patients with the LCI of the abnormal LCI. That means 23.5% of the 17 patients. That means LCI is more sensitive than the spirometry right now. So when we compare the FEV1 to LCI and LCI short extension, we don't find any right now, no correlation between the spirometry and LCI short extension, suggesting that spirometry may miss early small airways dysfunction. And here we compare the spirometry to oscillometry, and you see here with the AXZ score, only these parameters correlate significantly with the FEV1. That means oscillometry, especially the AXZ score, can be oscillometry parameter most closely associated with spirometric lung function in our cohort. So the oscillometry can be used and to replace the lung clearance index for detecting the small airway dysfunction in the early and the beginning of the cystic fibrosis. The lung clearance index and oscillometry outside limit. So here we talk about this new parameter, the under ventilated or unventilated lung unit. I say that's the result of the LCI short extension minus the lung clearance index, and this LCI and U value detected abnormalities in several clinical stable children, highlighting the greater sensitivity of the multi-breath washout derived indices. And when I compare oscillometry and under this indices to LCI, and I found here with the parameters of oscillometry F5 minus 20 Z score, there is a good significativity. That's a good correlation. So this parameter, the F5 minus 20 was significantly associated with this index of LCI U value under ventilated lung unit, indicating that oscillometry detects peripheral ventilation abnormalities. And this is the indices of LCI. So this is the slope conducting airways and the slope, the acinar region. And among the 17 patients, we found that there is elevated in 10 patients, and the second also for the conducting airways are elevated in 11 patients among 17. These parameters can orient us to in the future to try also to demonstrate that these parameters can give us also information about the heterogeneity. So ventilation inhomogeneity was common in our cohort and may involve different lung compartments. This raises the question of whether oscillometry can detect these different patterns of ventilation inhomogeneity. So the conclusion, oscillometry may serve as a tool for assessing early lung disease, so can track response to modulators, is sensitive to under or unventilated lung units, oscillometry and multiple breath washout derived indices, extended and underventilated lung unit detect early abnormalities not captured by conventional spirometry. So our next step is extend recruitment and conduct a longitudinal study, examine these parameters of the convective and the ascending region, and oscillometry, examine also intra-breath resistance and reactance. Thank you very much.
So, questions?
I do have one
Eric,
question.
go ahead. Yeah. Eric, go ahead.
I just,
Yeah.
how dependent is the LCI on the device being used to measure it?
Okay, so I wanted to speak to you about that. So there are two devices, the NDD and most of them are using the Ecomedics. The CF Mafia have decided, Paul, you can jump in afterwards, have decided that it's the Ecomedics device. I know there were some questions about the NDD. I don't exactly personally know why it wasn't, but I know the NDD device will measure lung clearance in that. And actually, I was going to speak to after presentation about, since you are already going to use it for FRC, that to also look at LCI. But I'm more than happy to have other people chime in on that. Nathan.
Yeah, hi, great presentation. I wasn't sure how many of the patients that were abnormal with normal FEV1 had abnormal lung clearance also had AX scores, which were abnormal, Z scores that were abnormal.
I had 4 patients with abnormal LCI, and all our patients have a normal spirometry. Because when we recruit,
but in terms of the AX Z scores, how many were abnormal?
2 patients.
Okay, so there is an overlap between normal and abnormal. Again, you probably have to, once you do your big study, you're probably going to have to find out what the threshold is, because it's not going to be it's not going to be a Z-score of 1.64 probably.
Right.
We have 17 patients for the moment.
Yeah. Other question? Side again, really quiet. Nothing. Yeah.
So in terms of mucus, you showed a few images there. Have you actually imaged to see that there is any mucus displacement following this maneuver?
No.
And has there been any consideration in terms of using that deep breath as having a bronchodilatory effect, separate from just the mucus, where in CF you might have airway thickening or some of these other mechanisms that deep breath inhalation triggers that bronchodilatory effect, that you might be getting some non-mucus components to this as well.
Okay, but with our oscillometry, well, there.
So we do the test in the same day, the test. They don't take any bronchodilator.
So what I'm referring to though is that slow inhale, exhale maneuver you've got at the end, which can have a natural physiologic bronchodilator effect that's not a pharmacological
right,
one.
But we didn't look at there was changes in oscillometry with that.
Thank you.
Paul.
Hi. So I think Chris Short has recently published some data with oxygen enhanced MRI, looking at progression of disease in kids on subjects on ETI. So the reason I bring that up is because it's that idea of kind of understanding what the MBW and that modification to the MBW test is then matching with on imaging. And so I think it will be interesting as you try and compare the MBW data with imaging data and then also oscillometry data is just kind of bearing that in mind in terms of thinking about how the oscillometry and variations of oscillometry then kind of value add, hopefully, for over a shorter duration of testing, because that might be an aspect that makes it a little bit more feasible in busy clinics.
Yeah, I'd love to add in imaging, but finances is such a so we're probably not going to get that. And yes, there is a correlation between the underventilated regions using the extended LCI and mucus plugging scores. But so I'm not saying place one with the other, but at least there's a correlation there.
Well, I think the value of those kind of studies, and I'm not suggesting that everyone does it, is it's useful to try and understand exactly what it's representing.
Yeah.
Because I think historically, looking back, with that idea of trap gas, because Per Gustafsson originally did it with 5 kind of IC maneuvers, and then Chris adapted that to be more of a single VC maneuver, is that we tended to think of that as trap gas. But the reality is it's probably a mixture of the two. There is some trap gas, and a lot of it's kind of just very poorly ventilated regions, which kind of makes sense. So it helps us kind of understand what those indices are telling us. And then I think how oscillometry correlates with them is going to be useful because, I mean, I'm a fairly strong proponent of MBW, and we've been able to do it within kind of busy clinics and actually do it to a pretty acceptable degree. But if we have an even faster test, that's going to allow us to really kind of track kids on a clinic to clinic visit kind of approach, which we can't do at the moment with MBW. In Brisbane, we've got a large clinic in Brisbane, 400 kids. We've probably got 100 of those that are preschoolers, and we do MBW at least annually on all of our preschool population, and we've been able to show that's feasible to do. But if we wanted a test that was going to be able to be done every single time they came, that's not MBW, but oscillometry might be if we can find the right way of looking at the data.
Right. Great. Okay. Well,
Thank you.
Oh, there.
No, okay.
No. It's interfering. Fine. And so Kate is our last speaker. No.
Go up to Paul again. Always go to Paul.
Right. Okay.
No,
No, don't worry. I love the panic in the room. That's great. I love it. Okay. Okay. So, screen. And so without further ado, Kia Hamilton Smith from Colorado will continue our story of pediatric oscillometry, but in a different disease.
You're all staying very.
I'm going to give it.
All right, thanks everybody. Thanks for having me speak today. I'm going to tell you about oscillometry in to assess respiratory mechanics in dystrophinopathy, which we haven't talked about yet. Main disclosure is this is work conducted with one of my trainees. Molly McCoy is part of her fellowship research project, and now she is attending pulmonologist at Children's Hospital, Colorado, and she has a strong passion for taking care of children with dystrophinopathy. And we're also writing this up, so any feedback is definitely appreciated.
Yeah, you can touch that button,
Okay.
go up and down.
Okay. Well, frightening. Okay, so dystrophinopathy is a progressive neuromuscular disease with pretty significant respiratory morbidity. It's caused by a mutation on the X-linked DMD gene, and it's where dystrophin is absent or deficient in skeletal muscle, smooth muscle, cardiac muscle, and dystrophin is really the kind of a structural protein that keeps the muscle stable. It affects about 1 in 3,500 to 5,000 male births. So it's primarily males are affected, but some female carriers also have some dystrophin deficiencies. And so this disease is characterized by progressive muscle weakness and atrophy with ultimately a loss of ambulation and progressive weakness in the inspiratory and expiratory respiratory muscles, leading to low forced vital capacity, weak cough, atelectasis, increased respiratory infections and pneumonias, sleep disordered breathing, hyperventilation, and ultimately respiratory failure. So the current paradigm for monitoring disease progression relies on spirometry and the forced maneuvers that entails. And so FVC tracks lung function decline in restrictive disease. We use muscle strength testing with maximal inspiratory and expiratory pressures and peak cough flow to inform how effective cough is. And these measures really guide the clinical decision-making on when to start non-invasive ventilation or mechanical insufflation, exsufflation. And these are interventions that can really impact survival and quality of life. However, hard to do, really difficult, and a substantial proportion of these patients also have co-occurring neurodevelopmental disorders along with their muscle weakness. So getting reliable spirometry is quite difficult. And so we have the question of, can we use oscillometry? It's not really used in our practice at our hospital. And so we wanted to understand what that would look like. So there has been not very many studies of oscillometry in dystrophinopathies with some very variable results. There's been a small study from 2016 that showed that there was higher resistance and lower reactance versus controls and very poor correlation with spirometry, and that resistance may get better in advanced disease. More recently, in a study of 148 people, they found that higher resistance and lower reactance correlated with lower FVC, but the correlation was poor in Duchenne's versus spinal muscular atrophy, so two different kinds of neuromuscular disease. In a study of adults, they found that reactance was worse with lower FVC, higher resistance, lower reactance with dysphagia. And then more recently, in a small pediatric cohort with Duchenne's, higher resistance with moderate correlation with FVC. So a lot of variables. So we still have some unresolved questions. So what does it oscillometry really add? And then is it a spirometry surrogate or more of a complementary measurement? So our objectives for this study were to characterize oscillometry versus spirometry profiles in a cohort of patients with dystrophinopathy, and then evaluate relationships with different clinical markers of disease severity. So we chose ambulatory status, use of chronic systemic steroids, which is common for disease-directed therapy, and then a neurodevelopmental disability diagnosis. So this is a cross-sectional study of 50 male children and young adults with dystrophinopathy. Our age ranged from 4 to 27, with the majority between 11 and 19 years old, median age of 14. About half were non-ambulatory, and 3/4 were taking chronic systemic steroids, and about a third had a diagnosed neurodevelopmental disability. And so we operationalized this within normal clinic visits in the multidisciplinary clinic. They always get PFTs right at the beginning of their visit. So Molly, our fellow, just got right in there to get the oscillometry before the RTs came in to do the spirometry. And so it worked out really well in that context. And we did find that oscillometry is twice as successful than spirometry. there's a lot of struggle with getting interpretable results. So we had 42 out of 50 able to get usable oscillometry, where only 22 were able to do spirometry. A few more could do the MIPS and MEPS of the respiratory muscle strength. And so maybe surprisingly, I'm not sure, all of the oscillometry metrics, we looked at typical R5, R519, AX, and using the Ducharme equations, they look normal. No one had abnormal resistance using the 1.645 cutoff, and only 3 had abnormal reactance. This is compared to our forced vital capacity, where 64% of those who complete it had low FVC, and there was just absolutely no, any way you look at it, no correlation between oscillometry and FVC or the spirometry measures. And then also for the maximal inspiratory expiratory pressures, the majority had values lower than the cutoffs they use clinically to determine whether more interventions are needed, so below 60 centimeters of water. So looking at our kind of our 3 clinical outcomes, FVC, probably as expected, was decreased in the non-ambulatory patients, but there was no difference in resistance or reactance between the 2. And then for our 519, so with chronic steroid use, for those who were on steroids, they had a decrease in our 519 with a trend of decreased reactance as well. So probably pointing more towards this is reducing inflammatory processes and small airways, and also maybe why we don't see any major resistance reactance changes in this cohort. And then one of our kind of hypothesis driving findings is that AX was increased or worse with a neurodevelopmental diagnosis. And so our interpretation of this is potentially that the dysphagia or aspiration that may go along with that could be impacting small airways in some of these patients. And so points to a use case to investigate further. So overall, oscillometry in dystrophinopathy, definitely not a spirometry replacement, which is really needed to guide interventions, and normal oscillometry does not necessarily mean normal FVC, but it does reflect tidal breathing mechanics, and it may help in some patients to detect coexisting airway disease in people with dystrophinopathy, especially when it's not feasible, and then can be used to interpret discordant symptoms or clinical findings. And so some questions maybe that I have for discussion. Should we be looking at different metrics? It's very successful, so is there a different way we can utilize this, tailor this measurement for this particular population? What are the right reference equations or cutoffs that we should be comparing to, like a local cohort or other, any adjustments for lung volumes or tidal volumes? Just some things we'll be thinking about. And then in our next steps, we do have a longitudinal cohort started where we will be coupling oscillometry and spirometry with electrical impedance tomography, which will hopefully we'll gain some more insights about ventilation defects, and will be something exciting to tell you about in the future. Well, that's all. Thanks to the participants and families, our clinical team, and our staff team. Nice work.
Great, we get it. Charlie, go ahead.
Kate really presented very, very clear. And, you know, we always talk about how oscillometry, the ideal group to look at is the group you looked at, kids with lungs that make maneuvers. I have a couple of related questions. In the kids that couldn't do oscillometry, what was holding my.
I think the main trouble is like being able to have a mouth seal. So those were the ones with leak, or that we had a couple with autism that just really
Oh, right. Yeah.
are too young to kind of cooperate. And so I think having another potential way to improve is to have alternative interfaces where we can get a mouth like that are less reliant on a mouth seal.
Then the dissociation between FEC and the others was striking. I would imagine you'd have a hard time in these kids that get a reproducible FEC.
Yeah.
Is there a progressive loss of the FEC with each maneuver that they do, or
Yeah, they get really tired out pretty quickly.
So the problem really is they can't get it. They just lack the sort of respiratory muscle and coordination problem. Okay, thanks.
Congratulations. This was a very good example of the question of spirometry or oscillometry surrogate of each other. It's out of question. The other studies discussed me terribly because we know that they are different, and this is totally clear. And the 85% is remarkable. Thank you.
Right.
Okay, what I don't know is the literature in adults, chronic neuromuscular is associated with mechanical changes among study them appropriately. Do you see this in the accurate population, or is it unknown? You can do conventional mechanics like we used to with esophageal balloons.
Yeah, I don't know.
My question is, if the version of the mechanical changes that we see in the adult population, would the intra-breath methodologies only be something that would tease out differences that we're not seeing? In other words, for the oscillometry, breath reveal a signal that is lost spectral.
It's possible. It should be tried. I can't answer, but so to infer from the total respiratory impedance, which is pulmonary, which is chestful and abdominal compartment, and which is upper airway, from the spectral, very difficult to decide. The latter, the upper airway stuff, is very nicely can be very nicely separated because obvious from others. It might be interesting to see whether a simple title, which normally brings reactants down, for two reasons. One reason is if the lungs are not normal, PV curve is leaving the linear part of the PV curve not very likely in normal lungs. But the other one, the chestful compartment, which is even inspiration, and it's a big amount to the reactants. Whether they decrease more or less, that would be interesting to see.
Is the tremor for activated acquisition?
Yep.
Be interesting to look at.
Yep. It's on my list.
Before I get to Julia, do you have a question, Julia?
I do, yes. And it's so great to see you again, Kate. Hi. So I think this is such a really crucial population, right? As people have mentioned before. And especially since you just said it in person, like these kids, as you do more spirometry, they get more tired and then the data is honestly less accurate. And so even though the results of this study were a little disappointing, I would say, because everything was so normal, what are your next steps, right? I know Jules Allen put a letter in to the editor in Pete's poem about how they found more success with oscillometry when they compare to a local population. So are you planning to do that? Are you hoping to kind of use the oscillometry and track things over time? Because I could imagine your oscillometry in your 4-year-olds probably hopefully different than your oscillometry in your 27-year-old, because I don't really expect a 4-year-old to have Duchenne's associated respiratory problems yet. So yeah, what are you thinking?
Yeah, our next steps are to do, so we have funding to do a longitudinal cohort. And so we will be able to track every 6 months. We'll be doing measurements alongside spirometry and as well with imaging with electrical impedance tomography. And then as far as like comparison to reference, I think that's kind of a good question because I don't know, like we're using the pediatric ones that are device specific that have been published, and these are older, a lot of them are, older adults. So I think that's a open question. And then trying to look at, as we were just talking about, maybe some of the intra-breath to better understand the mechanics.
Right. And then we'll, I guess, we'll be eager. So then, last word, you're holding up.
Good questions. One is a more sort of practical one. When we do oscillometry, we want people to be positioned in a certain way and whatnot, and support their cheeks and so on. How does this work with this group of patients who obviously have muscular impairments? So how reproducible is that part?
Yeah, so they are the ones that are ambulatory. We just have them sit like our other patient populations, and then those who are not, they are in their wheelchairs and they're seated upright as much as we can. And I would expect though that if they were hunched, you would see higher resistances or reactances. So I don't, it's the ones that can do it are very repeatable.
Mine is more an observation. When I've interacted with people and they show me data with patients who have herniated diaphragm, or people with paralysis or partial or more or less partial paralysis of the respiratory muscles. And what I've seen there are a frequency dependence, suggesting heterogeneity, but also the recruitment of elastins. I'm surprised you didn't really see anything of that. Maybe your patients are too young. I don't know. As Julia said, maybe they haven't developed peacefully yet. I don't know.
Yeah, and they are mostly on chronic steroids. So
yeah, and also
they're inflammatory.
It's a different type of disease.
Paul, last question to you.
Hi, Kate. I'll be interested to see what you find in this population, just because the thing that's troubled me a little bit about the MBW kind of literature in this setting is that what I've seen people do is interpret a rise in LCI in this kind of population as a sign of structural lung disease. And what's worried me about that is that with disease progression, they have a kind of, they tend to have smaller tidal volumes. They have an increase in the dead space ventilation, which drives the increase in LCI. And so it's a physiological explanation for why the LCI is going up, yet it's interpreted as a structural, as a sign of structural disease, which kind of primarily comes from validation in the CF literature rather than this particular setting. So I think, when you're comparing it to EIT, I think it'll be interesting to see how you try and tease that apart, because I think that's the natural change in dead space ventilation that happens in this group as a disease progresses, I think does add in a degree of confounding. And it's going to be important to try and tease that apart.
It's a great comment. Thanks.
Great. Thanks so much, Kate.
Okay, so back in 15 minutes, everybody. Coffee should go at 5. Okay, everybody, please take your seats. We're about to restart the last of the morning sessions.
This is cool.
So Charlie, if you want to roll over here to be Mike.
All right, let's get rocking and rolling here. I got to earn my extensive honorarium.
Just your supper.
See, he signed me up to do 2 of these, but I thought he doubled my honorarium, but I realized 2 times 0 was still 0. So we have terrific presentations before lunch, and the first one is from dear colleague of mine, Chiara, and she informed me she's doing a tag team with her student, Elena. So that's why we have two ladies here, and they're from Milano, and they're gonna tell us about oscillatory applications in the neonatal intensive care unit. Ladies?
So thank you, Charlie, for the introduction. So, okay, so
Our technical assistant. Sorry, we just have to do this because I was informed. So, sorry about. Okay, so we want. This guy, and this is what we have to adjust over here. And we need to zoom in. So if you want to stand here, and then we have to zoom over this way and zoom in a little bit more, and then up. Now, where are you? You want to stand in front of the microphone so I can get you zoomed in? There we go. How about that? Is that a little bit better? It's universal for the next speaker too.
okay, so perfectly. I'm just going to briefly talk about why we want to introduce oscillometry in the neonatal intensive care unit, which are possible clinical application and methodological challenge we are going to face and how we are trying to solve them. So starting from why oscillometry in the neonatal intensive care unit. So preterm baby are nearly 5–10% of the newborns, and they are at high risk of mortality and complication. And because the respiratory system is the last organ to develop, they often need respiratory support. And the challenge is to provide them support for breathing without injuring the fragile lung. And this is very difficult also because this is a very heterogeneous population, because we have different gestational age and we have several different pre and postnatal factors that can impact the respiratory systems. And so it's very important to tune the respiratory support strategy to the condition of each newborn. And this is challenging because we have few instruments available at that side. We have chest X-rays, but of course they are not useful for monitoring. And then we have oxygen saturation, but it is an indirect and unspecific marker of lung ventilation and lung mechanics. And there are also other techniques, but they are just used for research, like the lung ultrasound or electrical impedance tomography. And so oscillometry, as it is, you can easily agree that is suitable for this population, can provide useful continuous information on lung mechanics. So which are possible clinical applications? The first one is optimized ventilatory parameters. For example, in this study, we measured the impedance during recruitment maneuver. The positive end expiratory pressure was increased starting from 2 to 10 centimeters of water and then decreased. And you can see here how the healthy lung react. So there is really a few change in reactance with increasing and decreasing pressure. And the situation is totally different when we have an infant with acute respiratory distress syndromes. And this is where the recruitment maneuver are performed to increase the recruitment of the lung. So we can see that the reactance, while we are increasing the pressure, is decreasing because we are stressing the tissue. But then when we come back, we reach a higher reactance value at the same pressure in different points. And this hysteresis of the curve testify that this maneuver was able to recruit some part of the lung. And so this measurement can be used to see the effectiveness of the maneuver by measuring the hysteresis, to see how much the lung was stressed by going to high pressure, to quantifying this decrease, and also to see which is the lowest pressure able to maintain the lung open. So at lower pressure, the lung tends to collapse again. And so oscillometry may have a role to optimize mechanical ventilation for these infants. And also for infants with chronic pathology, we found that reactants can provide important information. For example, this is mean curve of several infants, but we identify in some of these infants a decrease in reactants at low PEEP and also an increase in resistance. And we think this is linked with airways collapse because we have a reduced elastic recovery recoil in this population. Another field where reactants can be useful is to evaluate the treatments like surfactant administration, steroids, bronchodilators, and also the effect of recruitment maneuver. This is an example of recruitment maneuver at birth, and we have two infants that react very differently despite the same gestational age to the maneuver. In these infants, we can see an improvement of lung mechanics during the maneuver, and the reactants also decrease a little bit after the maneuver, suggesting that maybe the pressure that was maintained after the maneuver was a little bit too low for this infant. While in the other infant, the reactance was worsened during the maneuver and also after the maneuver. And this was because we suppressed the spontaneous activity of these infants. So it's very important to tune the treatment according to the condition of the lung, and reactants can help us doing that. And also now we have some reference equation available for preterm infants. They have been collected in preterm infants that didn't develop significant pathologies, and they did not require long-term respiratory support. And so it is possible to see for a new measurement relating to this reference equation, the severity of the change in reactants. And it's also possible to do longitudinal monitoring, of course, and see if the infant is able or not to catch up with the healthy one. And then also it's been proved that reactance measurement on the 7th day of life were able to predict the days of the respiratory support, the total days of respiratory support, and also the development of chronic pathologies. So it is useful also for prognosis. And also it's been used also for short-term identification for the need of surfactant administration. We can see that in this case, reactance measurement before the 3rd hour of life were able to predict infants that will need surfactant administration within the first 24 hours. But what was interesting is that we found also some infants with bad mechanical condition that didn't require surfactant according to the clinical criteria that now is just based on the oxygenation. Required oxygenation is a cutoff on the fraction of inspired oxygen, and in Europe is 30% now. They didn't reach this threshold for surfactant administration, and so our question is, are they compensating by increasing the work of breathing? Are they damaging the lung along this way? And so we split this group, the group that didn't receive surfactant, according to the length of respiratory support. And we found that these infants require long-term respiratory support. So what would have happened if this infant had received surfactants in the first day of life is a question that we want to address. So despite all this promising application, a recent review just showed that only 27 studies were performed in newborns with respiratory condition. And all of these studies include a low number of subjects, and all of them were only observational studies. So why? One of the main reason is the methodological challenge we have when we are trying to do measurement in this population. We just have one commercial device that then can be used only for intubated patients. So all the studies are done basically with homemade device, or using the commercial device but with external way to compute reactants, and sometimes in an off-label condition. And then there are no standardized procedure to perform the measurement, nor method for data elaboration. And we cannot use the same for adults because the breathing pattern is extremely different. And we also have a really marked intra-breath changes in the parameters, especially during the first day of life, because they are using the glottis and the vocal cord to increase the lung volume and during the expiration. And so we have also this artifact to deal with. And the artifact detection is challenging, especially for the non-invasive treated infants or for spontaneously breathing because of the glottis, but also because they have collapsible nostrils. And so when the doctors press too much the mask on the face, the nostril tend to collapse. And so we have also artifact related to that. And so now we are trying to solve some of the issue, and Elena is working on this in her PhD.
So as Chiara introduced, one of the main challenges that prevents oscillometry from being applied consistently in the NICU is the lack of standardized procedures. And this does not regard only how oscillometry is practically applied on newborns, but mostly how the data is handled for quality control. And this is why we have been focusing on improving methodologies for quality control in order to either correct for the artifacts or exclude them and obtain more reliable impedance measurements on this population. So we have been working on multiple fronts. I'll try to walk you through them all very quickly in the little time that we have. So starting from enhancing the data quality, there are a lot of aspects that need to be considered. And in order to address them all, we have developed a model that represents the patient coupled with the oscillometry device and is characterized with physiologically realistic patient parameters. So with this model, we can generate in silico oscillometry data and we can apply our algorithms on this data and evaluate their performance precisely because we know the parameters of the patient mechanics that we imposed. Up to now, we have been using this model to evaluate the effect of device characteristics on measurement accuracy and to develop filtering algorithms to preserve accurate tracking of intra-breath dynamics. We have also been working on algorithms to exclude the artifacts to perform sort of a cleaning process before analyzing the data. So starting from some traditional algorithms, we have developed methods that select one window per breath that is free from the artifacts and compute the overall impedance value as the average of the impedance in those windows. We have obtained very good results compared to the gold standards, but it should be noted that the validation on these algorithms was performed on a relatively small data set. In the meantime, we have been working on artificial neural networks that perform artifact exclusion. And in this case, rather than selecting windows that are free from artifacts, the network evaluates each breath individually and classificates it in either acceptable, so it's artifact free, or artifact contaminated, so it's to be discarded. We have trained the network on 1200 breaths and have obtained pretty promising results, but the network will be trained on larger data sets that we are acquiring in the meantime in order to improve its generalization capability. So the other big challenge that prevents the use of oscillometry in the NICU is the lack of evidence that supports its clinical benefit. And this is why we have been performing a randomized control study called the Remedies trial that will involve 17 centers across Italy with an estimated enrollment of more than 400 patients. And the aim of the study is to verify whether a gestational age-dependent threshold on respiratory reactants can better identify infants that require surfactant replacement therapy and therefore reduce delays in its administration. So all the infants get randomized into an intervention or a control group, and they all receive an oscillometry assessment, but the way they're treated depends on the group they belong to, of course. This study is made possible by an app that we developed and installed on tablets that get connected to the ventilators. And the app performs like all the phases of the study. And this includes impedance calculation and data quality control. So within the app, we have implemented the traditional algorithms for artifact exclusion that I was talking about before. And this is precisely why they've only been validated on a smaller data set. However, as the study progresses, we will have more data available on our population of interest, and this will allow us to further tune and validate all our algorithms. So to briefly sum up what we talked about, we have been working to tackle the challenges that prevent the use of oscillometry as a standard practice in the NICU on preterm babies, and both to improve the algorithms and improve the reliability of oscillometry on this population, and to prove its actual clinical benefit. So as our studies progress, we will have more data, and that this will allow us to further tune and improve our algorithms. And if the promising results are confirmed, this could be a step towards standardization of this technique into this fragile population. So thank you for your attention. This is our lab group, people that we work with. We're open to any questions.
So congratulations, this is very exciting. Pediatric perspective. A couple of things. So this can be done non-invasively, so externally applied CPAP. Um, nose and mouth, like both, because otherwise you have, okay. The other question is, so most of these patients are going to be on supplemental oxygen at various concentrations. So does the oxygen concentration affect the measurement?
Yes, so it can affect a little bit the measurement of flow, but in our experience, it was never an issue. Also because the concentration is not changed so much during the recruitment maneuver, even if it is adjusted. And so we think that it's not so worth it to try to compensate for that.
A related question. Is there a bias flow in the mask measurements?
No, there is a bias flow just in the circuit, but not is not with a leak. There is not an intentional leak. The bias flow is in the.
Because if it's flushed with higher oxygen content, then it would not change the saturation issues. The other question, if you plan to analyze intrabed changes, what is the frequency of oscillation?
It's 10 hertz. It's performed by the Fabian HFO, and it's 10 hertz.
Yes, it's the ventilator, we cannot change that. But in my experience, I always done intrabreath because in infants, I started with measurement during mechanical ventilation. So I have this huge square waveform of the ventilator. And what I did is always intrabreath. I try intrabreath even with 5 hertz.
Is it absolutely impossible for you to use like 16 hertz, which has been used in South Africa, Australia, Hungary, Bangladesh, throughout, and make things comparable?
With the commercial device, it's impossible. We can with homemade device or with just an old machine. We have an old version of this ventilator, but it's not in commercial one. So we are bound to do measurement just in one neonatal intensive care unit with our devices. And now is not even so easy to get ethical approval. But the commercial device has only 10 hertz, so it's not possible to change anything, not the amplitude, nor the frequency, nothing. Yeah, we will try to collaborate with the company to make them change something in the software, to make them available other feature.
But refer to the Fabian.
Yeah, for the Fabian, yeah, but we didn't succeed up to now.
David? Thank you both. That was really interesting. I'm intrigued by the clinical trial. If I read the slide correctly, all infants who require more than 30% FiO2 will automatically get surfactant. I assume that's the standard of care?
Yeah.
What will you do if the reactance threshold is crossed, but they don't require 30% FiO2? Will they also get surfactant? And that's sort of the exploratory part of the
interventional group, yes, we will get surfactant.
Okay.
Well, there's also the difference in time, so because when you do on-force oscillation, 3 hours lag, while the oxygenation is tested after at least 6 hours. So by using the 2 major effects we are testing is one, covering the population that is not requiring higher oxygenation, but we are also anticipating delivering surfactant in 3 hours, which should be
interesting. Thanks.
Did I understand this? There's a single sine wave, or what is the signal? So this is a control sine wave.
Yeah, it's a single frequency sine wave.
What frequency?
10 hertz.
So it's a 10 hertz.
Yeah.
All right. Fantastic. Thank you. The next presentation is virtual. Switch.
What? Oh. Selmer, I'm not going to try to pronounce your last name. I don't want to butcher it. Who's from Boston University, and he's going to talk to us about a really, sounds like a fascinating title, lung volume respiratory mechanics, non-invasive estimation during high-frequency ventilation. So I'm looking forward to hearing him. Salmar, are you ready?
Yes, let me
share with us.
Share my screen.
Yep.
Just a second. Okay.
Who's happening?
And let me know if you can see my screen.
Yes, I can see the screen.
Perfect. And now on to presentation mode. Okay, great. Thank you all for joining and for giving me the opportunity to present today. I would like to talk about how to estimate lung volume. It's just a study how to estimate lung volume in high frequency oscillatory ventilation. But just maybe before that, since it's my first time, I'd like to maybe connect with others. Just want to say how I got introduced into oscillometry. So I started maybe in my master's thesis. I was Professor Robert Habib back in Lebanon, but then it really advanced and I got to meet a lot of people. When I joined Boston University, supervised by Professor Belasuki, and met a lot of people in oscillometry like Jason Bates. Also, I see you're here. Good to see you. And Kenneth Luchin, as well as others. Unfortunately, now I work more in sweat mechanics, but I really love this field. So it's always nice to see what's out there and connect with people who have this similar passion. And now going back to the topic, just like the previous presentation told us, it's very important to really be, how to say, like assess mechanics, resistance, and compliance in order to choose the ventilation settings and optimize them on a per subject or a per preterm basis in this sense. Unfortunately, we all know there's not much let's say, available devices that can estimate lung volume that could allow us to ventilate around the sweet window where we can avoid ventilation-induced lung injury. So this work really kind of presents this model very exploratory to kind of estimate lung volume in high-frequency oscillatory ventilation. And just to talk about the background, this is data, this was a secondary study. So this is data that was already collected and published in 2012. It involved 7 infants that were ventilated at 7 mean airway pressures, 4 inflation and then 3 deflation, and had 3 different delta Ps using HFOV frequencies range between 5 to 20. And again, the idea was to find the sweet ventilation spot. And this is just an example of the data from one subject. It's filtered between 5 to 15 for this case. You can see that there's like a mean airway pressure around 10 centimeters, and we have 3 different delta Ps of 50, 100, and 150%. So that's just an example of the raw filtered data from one subject. And again, this is done in the primary study by Singh et al. Published in 2012. And so what they did is that they simply used the single 2-element model resistance and compliance to estimate the resistance and compliance for subjects. And they did find, I want to note out that they also found out that the inertance was 0. So there was technically no inertance. They did not estimate lung volume, but we took this data and wanted to estimate lung volume from it. And we also started from a 2-compartment model, the single airway, single alveolar unit, but rather than using a 2-element model, we wanted a 6-element model. We started with a 6-element model. And the reason we started with the 6-element model is because we were interested in the alveolar compartment, because the alveolar compartment or the gas compression, we believed could give us an idea of lung volume. However, there are 2 facts that we have to live with, unfortunately. The first fact is that inertance was not detected. So that means the airway inertance and the tissue inertance go to 0. The second fact is we also know, published by Casca et al. 1997, that at high frequency tissue resistance goes to 0. So technically our 6-element goes down to 3 elements. And if you look at this electrical model, you know that two compliances in parallel directly sum up to 1 compliance in technically. So in other words, we cannot separate gas compression from tissue compliance. And so we cannot estimate lung volume. At least mathematically, this is what this is showing us. So how did we solve, or how did we approach this problem? I won't go on a lot on the math, but the idea was that we tried to approach it using physiological mathematical equations. In other words, we know how lung volume behaves. We know it's a sigmoidal function. And so why not try to model, rather than modeling resistance and compliance, why don't we model the lung? And so in this equation, you can see this is the lung volume as a function of mean airway pressure and delta P, because we know that mean airway pressure increases the lung volume. So we expect how the lung volume is going to behave. So let's use mathematical equations to capture the settings.
or how the volume actually, sorry, how the volume actually changes. And this is true also for airway resistance. So let's use the mathematical equation that captures how airway resistance changes across settings. And then rather than fitting for resistance and compliance, let's fit for the parameters that give us this ventilator settings dependence. Again, just high level, the key point here is rather than fitting one single setting of mean airway pressure and delta P, what we did is we combined all the data. So we took all mean airway pressures, which were 7 in this case. We took 3 delta Ps, 3 different pressure amplitudes. So we put all the data together, and then using these mathematical equations of how the lung volume behaves, we fitted these mathematical equations rather than electrical model. I hope this makes sense. I know, sorry, this is a little bit technical, but if there is a take-home message, I think it will be this figure. So here you can see as an x-axis technically lung volume as a function of PAW. So we put all this data of baby 1, for example, at different mean airway pressures and different delta P, and we fit them all together. And here you can see the estimated lung volume from baby 1 as well as baby 3 at 2 different amplitudes, delta P's. And already you can see that, for example, in this case, baby 1 was ventilated at the lower inflation limb, was in general underventilated, whereas baby 3 was overventilated on the higher pressure volume limb. And you could see that the sweet spot in this case was around, let's say, 10 to 11 centimeters of water for baby 1 and baby 3. So the whole idea, the whole purpose of this kind of study was to be able to create this curve that could allow the clinicians on the bedside to, for baby 1 and even this case baby 3, 11 centimeters of water would be the kind of sweet spot of ventilation. And again, this curve, I think, is the take-home message from this work. Just also to mention that, just to show you more results, that we're not only estimating lung volume, but also can get airway resistance and tissue compliance, of course. And again, it is preterm specific. So baby 1 lung volume is different than the baby 5, again, because of the different mechanics of every subject. Baby 5, for example, resistance, that's the second row. You can see it behaves as expected. Resistance is going down with pressure. But for baby 1, again, it's a difference mainly from more nonlinearity, probably. And so again, you can see how this model is kind of subject specific rather than like very rigid and fixed. Just to show you more examples. And again, now we show the mean population. So those are the means of the whole population of these infants. In this case, 5 infants that had common mean airway pressures. And again, you can see now the physiology makes sense. RAW, airway resistance, is going down with mean airway pressure and increases with delta P, more linearity. Because of more linearity due to flow, tissue compliance is going down mainly with PAW, but lung volume overall is as expected, it's going up. And unfortunately for this preterm population, most of the subjects, as you can see from this curve, were ventilated at the lower limb, underventilated. And so in summary, the idea is that we're after estimating lung volume. The way we did it is that we used multiple data collected at different mean airway pressures and delta P, and we use mathematical equations that capture how the lung behaves in PAW and delta P, as well as resistance and compliance, to be able to estimate lung volume. Now, of course, there's several limitations. This was a secondary study. We didn't have the gold standards in order to compare. Of course, there are several assumptions in the model, and we could have used similar models. We also didn't do much of model variations. So in future directions, if anyone has some data with some gold standards, I think the idea would be to assess this model on actual data with gold standards to see how much the estimations match with the actual lung volume estimates. And with that, I would like to thank you for this opportunity to present, as well as all my mentors that really made me love oscillometry and science in general. And with that, I think it's time for questions. Thank you.
I have a question, Charlie. Oh.
Yeah, go ahead, Jason.
Of course, Jason.
Yeah, hi, Samir. How you doing? Good to see you again.
You.
Yeah, this is very nice work, sophisticated modeling, and I would expect no less from you. I will admit you zipped through the math of your lung modeling, your lung volume modeling a little bit too quickly for me to really get it. So I'm not going to get bogged down on that. But I wanted to bring up a sort of a general question. Maybe others could weigh in on this, but you know, there's been sort of arguments over the years about the fundamental importance of lung volume. Some people say you absolutely have to know what lung volume you're at. That's a fundamental parameter. I've personally never bought that. I've always thought that the fundamental parameter is lung pressure because that's what's distending the tissue. That's the measure of the stress that the tissue's under. And the other thing is that because of recruitment and de-recruitment and how that varies over time and hysteresis and all that kind of thing, you know, the volume you're at with a particular pressure may be different depending on how you approach that volume. So I just want to put that out there as to what is the fundamental significance of lung volume versus the distending pressure?
Well, I'll chime in as someone who uses high frequency in the NL unit. And frankly, I have to use my hand to see how low the liver's gone to figure out how low its lung volumes are. But there's a, you know, if you, first you want to recruit and improve ventilation perfusion matching, and then you overdo it. They're overinflated. I mean, they're basically vibrating around the volume that you set. So I think it'd be really helpful. I can't get them to do an X-ray, so I'd love to know what's happening with volume, because you're generating pressure, but you don't know if it's really being transmitted, and you don't know how much volume you're recruiting, and you'd like to find that sweet spot that you've recruited enough without over distending and causing.
So it's a matter of recruitment, basically. Yeah. Okay, that's fair enough. Yep.
Okay, Zolly.
Thank you, Summer. It was very nice to. A little bit difficult for me to follow the maths as well, but was happy to see again the boys' 6-element model, as well as my old colleagues from Boston. But I have two questions. What were the actually measured primaries in the setup? Second question, did you account for the endotracheal tube or not?
Sorry, if you could repeat the questions.
Question one is,
what physical quantities did you measure?
I see. So what we fitted for, maybe let me share, is pressure and flow. Let me share again. Airway pressure and flow. Yes, I know. I knew Jason Bates would say, "Hey, where's the equation?" No, I also expect nothing less. So let me. So what we fitted at the end was this equation: the pressure, the usual pressure flow equation, tracheal pressure, with flow, which was also integrated to find volume. And now the difference is that usually we fit per setting, one combination of settings, one mean airway pressure, one delta P. And we fit, let's say, for airway resistance and compliance. But now, for example, rather than fitting for airway resistance, we're fitting for this whole equation that captures airway resistance that has, in this case, 4 parameters, R1, R2, R3, and alpha R. That capture how airway resistance behaves. Same story for CG. As you can see, CG is a function of the lung volume, and the lung volume is given by this power law that allows us to capture the sigmoidal function. And again, it's a function of 4 parameters, V1, V2, V3, and alpha, that capture how, for example, it changes with the mean airway pressure and how volume could change with delta VM. So maybe I feel a little bit better now going through it a little bit, showing more of the math. But this is
Does that final equation, that VM1, does that include a strain stiffening term? Is that what that last thing is?
Yes. Yep.
So the line gets stiffer as it gets more inflated. Okay, thanks.
And this P over here, so technically this is what we're saying, that part of the airway tidal volume, so you have the tidal volume coming in, part of it will change the lung volume and part of it will compress. So this is this P portion here. So the larger the lung volume is, the more you can compress the gas, but the more the stiffness also, so the change in volume becomes less. So that is one physiological assumption that we made that's built in this math. So maybe that,
Zolly, you had a second question.
yes, so that hopefully answers the first question of what we fitted.
Yeah, thank you. Second question is, did you measure tracheal pressure or airway opening pressure? Was the endotracheal tube included in the resistance or not?
Yes, in Singetal, I should have mentioned it. What they fitted is tracheal pressure rather than airway pressure. Correct. So we already kind of had tracheal pressure. They had airway pressure. They did have airway pressure, but yes, in the model, they also did calculate tracheal pressure, and we're only fitting tracheal pressure with flow in this case.
Any other questions? Okay, well, thank you very much.
Thank you again for the
Great.
opportunity, and good to see many good faces.
So our next presentation is from an old friend. Hello, Brad. Brad is trained with us down in Vermont with Jason, and Kate did as well. And to our regret, he had left. A mistake on our part, for sure, and has gone now to the Anschutz in Denver.
Yes. Yeah.
You lost it? Oh, there it is. No, there it is. You're at the Anschutz. So, and you're going to tell us about ventilator-induced pathogenesis. Oh my God.
Yeah, shocking to those who know me.
Wow. Okay, well, rock my world.
Don't have a photon.
It's amateur. Can you guys see it out there in TV land?
Are we good to go on the internet?
Hello?
Interweb?
Yes,
people?
we can see. We could hear.
Okay, very good. All right, I was a little worried about this talk, given all the clinical focus, but the last two have given me hope because this is, I think, just a more broad perspective on the ideas in the last two talks, right? In terms of optimizing ventilation, using measurements. And I know at least one person is going to be interested in this, and Jason as well. So, you might be on a ventilator for many reasons. You might be a preterm neonate with insufficient surfactant. You might be undergoing surgery and Gabe is trying to titrate your anesthesia, or you might have acute lung injury and you just can't breathe on your own. Anyway, you cut it, villi might occur, right? This could be due to overstretch if pressures and volumes are too high. This could be atelect trauma occurring if pressures are a little bit low and you're getting cyclic closure and opening of small airways and alveoli. But either way, these are going to damage the blood gas barrier, cause leak, and worse clinical outcomes. So the worse job you do adjusting the ventilator, the more villi you're going to see. Unfortunately, it's not really easy to walk up to the machine and be like, yes, this patient should be at a PEEP of 9. And there's no clear readouts to date of what identifies an optimally safe bit of ventilation. There's no number on the machine that says, this is perfect, you're good, stop twiddling the knobs. This is confounded by interpatient heterogeneity. If you figure out that PEEP 9 is great for patient A, it might be PEEP 16 for patient B. And these are going to change over time, right? As these patients either worsen or resolve. So something we've been working on, I would say for about forever, is trying to use computer models to identify optimal ventilation settings. And here we're looking at PEEP because the positive end expiratory pressure, that's one of the main levers that we have. So to do this, we first conducted some experiments in mice to collect the data. These were either initially healthy controls or suffering from intratracheal hydrochloric acid injury. That was 2 days before the experiments. The day of, we either sacked some of them for biomarkers and histology or put them on the flex events. And on the flex events, we first measured mechanics during these PEEP ladders, where we'd start at a PEEP of 0, ventilate per minute, take 4 measurements, force oscillation measurements, and calculate elastance using the constant phase model. Then we step up to PEEP 3, measure again, 6, 9, 12. inflate to a pressure of 30, measure P12 again, and then march back down. So this is similar to the first documentary section, looking at the neonates, except we did a little wider range of pressures because we're not as concerned about the mice as they are about the babies, I hope. After that, 4 hours at peeps of 1, 3, or 8. These were separate cohorts of animals. And at the end of it, another peep ladder, and then either histology or biomarkers. So what does this data look like? This is in orange, the hydrochloric acid after PEEP1 ventilation, the controls after PEEP1 ventilation, and I'll walk you through these elastance measurements, right? So we start at PEEP0, lungs are de-recruited, and we're stiff. As we increase PEEP rate, we're coming down in elastance, less stiff, and again, then we start to increase as we get this strain stiffening of the lungs. So we're going from atelectasis into overdistension. We hit that recruitment maneuver, that opens up a little more lung. Then we come down the ladder, we're reducing elastance, stiffness, right? We're stopping overdistension. Then we pop back up as units close again. It's a thing of beauty. I'd like to highlight here the hysteresis, right? So at, for example, PEEP3 on the ascending, we're higher than the PEEP3 on the descending. And that's because these units have not yet opened. The recruitment pressures are higher than the de-recruitment pressures, which they must be. So this is great, but I feel like if you showed this to someone in the clinic, they would say that's very useful. Not at all. What do I do with this? And I believe Gabe is suffering from that right now. So what we wanted to do was try to decompose this into some more useful information that we could use to guide ventilation. And this idea is a single compartment model. It can stretch vertically to represent tissue distension, horizontally to represent something we call the compliance factor. This is predominantly recruitment, but there's other effects in there. So we wanted to be safe about this naming. And this goes back to, I think, a 2014 or 2015 paper that Kate and Jason did with this idea. Just kind of building off of that. So this compliance factor spring, when it's 1, right, we're just using our tissue elastance to represent the lung. When this is less than 1, the compartment's narrower. So at a certain volume, you're stretching that spring further, the elastance spring, and it's going to be stiffer. If this compliance factor is greater than 1, right, we have a wide compartment. So with the same volume in the box, you're going to stretch your tissue less. And Jason, I deleted most of the equations, but I left one for you. So looking first at the elastance, right? This is constant at low volumes. We hit a threshold pressure, P crit, and it ramps up past that, in this case, second order. We calculate this constant elastance by just using the lowest value we got in the control animals before they had any villi. We're just calling that the least you could get. Then this P crit and E rate we get through the model fitting. Our compliance factor is the fun part of this, and it is 2 Gaussian cumulative distribution functions. This green one is representing inspiration, right? So we have a higher pressure where we're achieving the same level of open lung, essentially. And then on deflation, right, we come down here, we stiffen as we go down in compliance factor, and then we reunite at low pressures. There is an offset between these to account for that hysteresis that we saw in the elastances measured during the PEEP ladders. And we allow different slopes here because we need to get it to float. So for this one, we get the maximum compliance factor by just taking the volume of the PB loop for this animal over the volume of the PB loops averaged for the control. So that caps the top of this. And we get the other 7 parameters through numerical optimization. It takes about 5 minutes on a workstation. So we could do this in near real time. All right. So what are we representing here? This is an example of that compliance factor curve. If we start off at low volume here, right, we've got a lot of closure, a little bit of open lung. We inflate, recruit a little bit. We keep coming up. We've popped open more lung units here, not all of them, right? We haven't reached that control level of 1. We come back down. we have more open lung at that same pressure, right? Until we return back to our starting point and everything is in balance. And I should point out that this is not necessarily complete recruitment. It could be septal folding, as Lars showed us. And these are the model fits. So there's about a dozen mice in each of these subgroups. Top left is all of the controls. So at high volumes, right, we're representing the dynamics just with that nonlinear tissue elastance. And as we come down in pressure below about 8, we start to see a stiffening, a drop in this compliance factor, that's septal folding, and some derecruitment at very low pressures in these controls. In the hydrochloric acid mice before ventilation, right, we've lost some of that peak compliance, so they're generally stiffer overall. And there's more hysteresis here, and you'll notice a more gradual slope on that recruitment curve. This gets worse when we ventilate these mice, particularly the HCl peak ones. These had the worst outcomes. They were profoundly underpeaked. We see more hysteresis, a greater loss of that peak compliance. And this is slightly less bad as we go up in PEEP in these HCLs. In the controls, a little more hysteresis, not much of an effect. They're much more resilient. So we went deep into this and made some very confusing plots, which is in Liz's paper, which is HAP lung last year. So if you're interested, find me after and I can give you a copy of that. But what I'd like to focus on today is trying to use this to link to Vili. And these compliance factor curves are kind of like a general description of the physiology or pathophysiology, but they don't incorporate the ventilator settings, right? There's nothing in this green line and this red line to state what we set, PEEP2, tidal volumes, pressures, whatever. And so what we've done is added in the dynamic plateau pressure, just the pressure from the end of the breath and the inspiration, and the PEEP, positive end expiratory pressure, use that to bound this gray area inside of the curve. So these are measured in minutes 5 to 15 of the ventilation. We gave them a few minutes to settle down, took the average PEEP and plateau pressure from those many, many breaths in that 10-minute period, colored in this section, and we're calling that the CF vent area, which is not a great abbreviation. I'm gonna regret that. This is at HCl PEEP8, right? So you can see this is a much larger area in this pre-injured mouse than our healthy control at PEEP3. And this correlates remarkably well with outcomes at the end of the experiment. So here we've got bowel total protein. So we rinse the lungs out, look at the amount of protein in that fluid, and an R squared of 0.86. I'm quite happy with that. And so we've done this for a few things. I also show here CXCL1, which is the mouse IL-8. This is measured in the bowel. And again, nice correlation with this marker of inflammation induced by the ventilation and the HCl injury. You might ask yourself, why go through all of this work? Can't we just use some existing marker? If you play with ventilators, you'll know the driving pressure. If not, that's just the difference between PEEP and plateau. So if we look at this correlation with total protein, R squared of 0.23, not that impressive compared to our 0.86. And mechanical power, also popular in the clinic these days. And this can be calculated by integrating the product of pressure and flow during inspiration. We've done that, and we see a slight inverse correlation with our injury. And this is really driven by the fact that the HCl PEEP8s, which were most protective for the pre-injured mice, have a lot of PEEP that contributes to the power. And so those were the highest power, but most protected. All right. So in summary, we caused Vili in mice. These were either healthy or pre-injured. We fit this computer model. This gives us both a measurement of the existing injury at that point, and the ability to combine that with measured PEEP and plateau pressures to try to predict Vili. When we do that, there's a nice correlation there. And this has inspired us to, as we're doing this week, try this prospectively in mice with a different injury model. And I have high hopes for this, but I kind of fear that we might have injured our mice too much and it's going to muddy my results. because I looked at the data before we came up here and we're getting like a 6-fold increase in elastance. And I think we might have gone too far. So we might have to repeat that experiment. But I will hopefully report back next year that this works smashingly. All right. And I have to thank Liz here. She did basically everything here. She graduated this spring, moved back to her hometown in Rhode Island. So if you're looking for an excellent postdoc or someone in industry, get in touch with me. I can put you in touch with Liz.
Right, I have a question.
Yeah. Oh, you did. Yeah.
Yeah.
Shocked.
Oh.
Fire away, Jason.
Hi. Yeah. Well, it's a very interesting presentation, Brad. I'm glad to see you're pursuing this stuff. And one question particularly is, you get the hysteresis, inspiratory, expiratory hysteresis by having that compliance function.
Yeah.
But you don't have dynamics built into the recruitment and de-recruitment.
In terms of the time dynamics.
In terms of the timing, yeah. Am I right about that?
You're correct.
Yeah. Did you think about building that in? In other words, instead of just a spring, you have a spring and a dash pot in some kind of arrangement?
Yeah. So I went through probably 2 years of increasingly complex models, trying to get those fits to be robust and not take like 4 hours of compute, and was unable to achieve that goal. And so we
even with a simple model, even with that simple one compartment model.
Yeah, it's like the error surface is very rough, right? And so we really struggled to get it to fit, or we could like get it to fit quickly, but if you ran it 10 times, you'd get a different answer each time because it was getting stuck in local minima. So you had to like really, you had to like
because I'm thinking if you had that in there, it might enable you to predict what's going to happen with different modes of ventilation, like APRV versus volume control or whatever, you know.
Yeah. So like say you like shorten the inspiratory time, you might prevent like the cyclic recruitment. And then so the other challenge there is when we did this, we had to feed in a profound amount of data to get it to fit reliably. And it seemed that we would never be able to get that information clinically, you know, for the kind of dream goal of like actually doing something helpful.
Yeah, fair enough. No, I understand that. And the other thing is, I think your data is showing that the elastic power has got no bearing on injury, which is not exactly a surprise, but it's good that you showed that.
Yeah, if you drop off the PEEP component, it does all right. You know, if you look at the resistive and kind of inflation elastance and remove the PEEP, it's okay.
Yeah, well, your PhD supervisors, I'm sure you know, led a study last year showing that it was the de-recruitment power correlated with injury. Yeah.
Very good. Yeah, Brad, wonderful data and very thought-provoking. And I just want to comment on Jason's comment as well, because our data with the clinical models in lung using imaging to measure recruitment. Now, particularly interested by your remark on mechanical power, because mechanical power, in the absence of completely in agreement with the paper that Jason mentioned, it does not produce stability.
Yeah.
Whereas as soon as you have some recruitment, de-recruitment dynamics, then the same mechanical power or even lower, and it will induce. So that I think is a crucial point, because there's no way at bedside that you can actually, besides EIT, and we'll see how good EIT works in measuring dynamic recruitment.
Yeah.
But CT imaging certainly, which is the gold standard, it gives you a very nice. So we have data. I'd be interested in looking at your retrospectively looking at your area.
Yeah.
Computation to see how well that predicts really.
Yes. And I should point out that we used oscillometry to get those elastances, but they could just be derived from, single compartment model fits. There's conceptually, there's no barrier to doing that. Which we have a huge clinical data set. Unfortunately, it's very devoid of PEEP titration. They just pick a setting and go with it. And so that raises another good point, and that's the potential for disagreement between these things, right? Gabe's been seeing that if you use EIT versus best compliance, like they might not agree. And then, you know, picking the one that works best is.
Really neat. I don't understand the introduction. Before your goal at the outset was the introduction of the compliance factor to help basically set the ventilator settings.
Yeah.
To do better for my patients. So the compliance factor goes, it's not compliance, but it's going down at very low pressure, which I assume is due to the stiffening as I'm closing things, de-recruiting things. But at the top, the compliance factor is very flat, so it's not compliant. And it's somehow, is it accounting for the nonlinearity at the low end? Like I have to actually, if I have a linear model for compliance, it's not going to work for the nonlinear V curve, and it's not going to account for hysteresis. So the compliance factor at the low end is something accounting for the nonlinearity. But at the top end, I'm confused.
Yeah, so at the top end, the like kind of base elastance is handling that. And as the compliance factor is shifting down below 1, it's essentially ramping up that nonlinearity in the tissue elastance. Because
so it's a factor that accounts for the inability of the model so far without it to account for the nonlinearity at the top.
Yeah, and well, we also, I think we wanted to be able to scale out that the nonlinearity at the top, because it just, you know, the more de-recruitment you have, the more quickly you ramp up, right? So we just kind of knock down that compliance factor, and that makes you ramp up in pressure more quickly.
It's a factor that's focused on recruitment. Like
Yeah.
You don't expect it.
Yeah, and we had originally called it the recruitment factor, but then someone was like, you can't do that.
Scaled out that factor at the top. You
Yeah.
wanted to not be part of your decision.
Yeah.
You just want to put it at the bottom. Okay.
Another question?
Yeah, Dylan Casey.
Oh, I'm sorry.
Vermont. Are you taking measurements during that recruitment maneuver? Because it seems to be better to be coming down in peak.
Yes.
Because it also had you had a flatter compliance factor as well. So how is that injurious? Like the actual recruitment maneuver itself? Because should we just be doing that every 10 minutes or
so we
something?
do a recruitment maneuver every half hour.
Okay.
Or they die. And I think Lars has found the same in his rats, like every half hour or so. We just give them a 3-second inflation to a pressure of 30 and then come back down.
Okay, so that's during the 4-hour.
Yeah. So yeah, every 3 hours, RM. And when we were doing the kind of like individualized titration, we would make this calculation, do a recruitment maneuver, and then apply that PEEP.
Okay, but are you looking at the lessons and?
So we continuously measure pressure and volume from that. So we could, the data's there, but we're not doing anything with it right now. Yep. You want that data?
Yeah. But are you doing like multi-frequency oscillations during that, like on top of the?
No. So our oscillations are just at a kind of set pressure. It's not like an interbreath thing.
Okay.
I think the tidal volume is like 4 mils or something per kg.
But what pressure are you going up to for the recruitment maneuver?
30.
30?
Yeah. Which is like the standard setting on the machine.
Yeah.
Okay, well, thank you very much, Brad.
Thanks, everybody.
Right, so our last presentation.
We lost a mic coming on.
Is somebody who does need an introduction. Raffaele De Luca from Milano, who's an amazing bioengineer, but he has even a more amazing talk title. And it's oscillometry for lung function testing in unconventional settings, mechanical ventilation to the sky. So as remarkable as he is, he's now going to ventilate the sky, and I'm really excited to learn how he's going to do that.
Thank you, Charlie. And thank you also, Ron, for the invitation and for running this event. So this is my first time here. I'm very happy. And I will be sharing with you some results that we
some preliminary results on a study that we are running together with Bruce Johnson from the Extreme Physiology Laboratory in Mayo Clinic. So this study started as I think we started about 5 years ago talking about some extreme physiological condition in which lung can be affected. And I didn't know about this, so Bruce was teaching what's happening to the pilots when they are doing some specific maneuvers. And actually, you know that they can get very high cranial caudal acceleration, up to 9 Gs during the maneuver. And what happens in the body? The most important phenomenon we know is the displacement of the blood from the trunk to the limb, the lower limb. And this may produce, as a result, the pilots may be fainting. So in order to counteract this phenomenon, they are wearing some specific inflatable garments that are used to push, to apply a pressure to the lower limbs all the way up to the abdomen. And this is able to restore or to preserve at least part of the cerebral perfusion. These garments, however, they have a major impact in the lung mechanics because they are increasing abdominal compression and limit the possibility of the lung to expand in the lower, in the caudal direction. So depending on different flight conditions, on top of this challenging situation for the lung, the pilots are receiving some oxygen because the cabin pressure is not controlled as in standard aircrafts. So they need to have a FiO2 that can range from 60 to 95 or 100% oxygen concentration, which is also a factor that can promote absorption at telectasis. If you combine all these 3 factors, what happens is that we can have some subclinical and potentially reversible conditions that are named acceleration at telectasis. There is a good literature about this, but the problem is that if you want to study the physiology on when the acceleration is developing, you should be able to monitor lung mechanics during these high accelerations. Most of the studies are actually based on measurements that are performed immediately after the acceleration is applied. So this, as I was mentioning, acceleration at telectasis, they are related to subclinical potentially, to some conditions in pilots that have been reported because if repeated with time, they can promote inflammation, electrical trauma, and they may affect gas exchange. So the aims of our study was to develop and validate an experimental oscillometry setup for testing the possibility to monitoring continuously mechanical respiratory mechanics during these flights. With this device to quantify the effect of increasing the acceleration on the lung impedance in spontaneously breathing healthy subjects. This study was partially supported by the US Air Force, and I'm going to show you some of our preliminary results. So the first issue we had to solve is how to apply force oscillation in such an extreme condition. We know that most of the standard approach for applying force oscillation are relying either on loudspeakers or in other voice coils type of actuators. But all these systems are too fragile to be exposed to very high Gs, so they are not suitable for the application. Moreover, they tend to be also cumbersome. So what we did was to use another approach that is now used more frequently in different devices. That is the radial fan-based oscillometer approach. What you can see here is an example. The system setup is extremely simple. We have a radial blower connected to a brushless electrical motor. This blower is, the technology that is very similar to any conventional mechanical ventilator, blower-based mechanical ventilator. What is different is that the technology nowadays allows us to have extremely dynamic systems in which we can control the speed of the blower and change it with very, very fast. So these blowers are used to push, to create a flow that is applied through a tube to the patient, and we measure pressure and flow at the inlet of the patient interface. if the connection between the blower and the pneumotac is very long, an intentional leak will allow to have to reduce the dead space with a setup that is typical for non-invasive ventilator. So actually, this is very similar to a non-invasive ventilator. This is an example of the performance that you can get if you create force oscillations by properly controlling these motors. As you can see, you can get a very good ventilation waveform, but you can overimpose to the ventilation waveform also high frequency sinusoidal forcing. And thanks by using this technology, we were able to get all the way up to about 25, 30 hertz. So they are very, very responsive. Moreover, with a proper control for the pressure, you can also keep the pressure extremely stable, and therefore you can reduce the load that is perceived by the subject during the moment. So we apply this approach in different settings. We created several mechanical ventilators we are using for animal studies. Actually, we use also the technology to study impedance in horses. We did collaboration with Philips for mechanical ventilation. And this is an example of the handheld oscillometer that is using the same approach for creating force oscillation. So this is the device that we created for doing our studies. Here you can see the blower is contained in this I mean, this is used also to cool down the motor, but actually it's just a plastic container, 3D printed plastic container. Inside there is the motor that you have seen before. Here there is the connection to the patient, and we had some sensors that are applied, connected just to the patient interface. Patient interface, we use this full face mask. The mask actually was used just to support cheeks because we cannot use the hands while we are flying. And internal to this mask, especially for the pilot, is nice. They use the hands for other purposes. And then we also connected this 3D printed mouthpiece just to be sure that we were measuring the input impedance without being affected by shunt or leaks. So the first test was to see if the device was able to do accurate measurements in such challenging conditions. So we created our own oscillator, let's say oscillator centrifuge that was able to get the system apply to the system acceleration up to 9 Gs. And we also added a test lung. You can see here is a simple mechanical test lung that was used to evaluate the performance, the overall performance of the system. Here is the blower. Here are the sensors, and this is the electronic board that was used to control the system. So the results from this test, this is just how we compute the impedance of our test lung. Of course, we had to use test lung that were not changing properties during these acceleration conditions. And here you can see that the results were extremely positive. Here we tested the different positioning of sensors and the blower compared to the direction of the G vector. And the maximum error, as you can see, is really, really small. And this is a graph reporting how the measurements of reactance and resistance were changing by increasing acceleration from 0 up to 9 Gs. As you can see, the maximum error is very limited. So we're very happy about these results, and we started with the first study. The study protocol is represented in this slide. We involve 7 healthy volunteers. They were the students in my lab and myself. Volunteers is probably a little bit. Anyway, they were happy at the end. We were performing oscillometry continuously during the full flight. And we were in standard condition, we were cycling frequencies by moving from 5 to 8 and 11 hertz. Duration of each of the frequency was slightly different because with 5 hertz, we wanted to have a little bit longer time to get stable measurements. And then we use also 5 hertz only during some slow vital capacity maneuvers. The resistance and reactance were calculated both during normogravity and acceleration in hypergravity. So this is an example of the standard flight. We were doing measurements at baseline, so at sea level. And then with the aircraft, we were going all the way up to 9,000 feet. So it's something that is it's not that too much. I mean, it's just an altitude that was able to evaluate the changes due to the air density, but not to create the need of oxygen or create discomfort to the subjects. And the test was done by repeating, by measuring with oscillometry the value of the impedance during standard flight or during a very, very sharp turn that was allowing us to create this increased, I can show you this graph. So this is what was happening. So this is the tablet that was controlling our unit and reporting also the acceleration to the pilot. So you do this very sharp turn that allows you to increase the acceleration, but keeping the same altitude. So it's not a parabolic flight. But you keep the same altitude. This means that we do not have changes in gas density, but the only effect that we can measure is just due to gravity. This is an example of the full flight. You can see that there are just periods between the different maneuvers, and the maneuver this is the GPS tracking for the system that was showing how the test was done. Okay, the results. Impedance versus altitude. So first, we know that there is a change in gas density. So we wanted to see what happens to the lung of an healthy subject. And actually, we were very happy about the results. The resistance is, very flat, no big, as expected. We are healthy subjects, so there is very little contribution of the turbulent flow. So we were happy about the results. And also, if you look at the reactance, we see that there is a little bit of a trend with the reactance reducing with altitude. And we did some calculation by considering a simple model. Most of this change, actually, all this change can be attributed to the change of inertance that is related to the reduction of the density of the gas. And here is the effect of the acceleration on the lung impedance. Here you can see the resistance and the reactance, the resistance being on the top. And the most important difference was observed in the reactance that got more negative, and a slight tendency of an increased frequency dependent of resistance, very, very little. So first interpretation of these results is can it be due to also changes in lung volume? Because when you are receiving this, so we analyzed the tracings, and this is an example of tidal breathing. The subject was doing standard breathing before and at the onset of the maneuver. As you can see, there is no major change or significant change in FRC. So we can see that the volume was not changing. And this is the average difference in FRC for all the subjects. So you can see there is more. So this is suggesting that what we are actually measuring is the distortion, internal distortion of the lung with the compression of the lung base. And this data seems in agreement with this. So in conclusion, blower-based oscillometry is feasible and provide accurate measurement during this flight condition. So I think it's a technology that can be applied in many other settings for measuring, monitoring lung impedance in very unusual settings, let's say outside lung function test laboratory. By using this approach, we could also integrate the small blower into the oxygen delivery system that are used by pilots, and actually the pilots are already wearing a full face mask, so it's something that can be relatively easily integrated in the systems, in onboard systems. The altitude related changes in impedance that we measure in healthy subjects are consistent with the theoretical prediction. And as we saw, we were able, with this technology, we are able to monitor and see what happens in lung mechanics during the execution of this maneuver. So the next steps for us will be to increase the acceleration. This was just a feasibility study, so it was extremely helpful. But it's interesting that with the measurements, the changes that we observe are only with doubling the gravity vector. So it's a relatively small change compared to the 8, 9 Gs that some pilots can sustain. And of course, we are not using oxygen-enriched mixture, so the development of arc electrolysis will be studied by using this. Okay, thank you.
Wow. Great talk. I mean, to talk about the altitude dependency of reactants is better than the frequency dependent resistance. What are your next steps? Are you moving this into military applications? Are you partnering with your Italian or other air forces within NATO? What are you going to do?
So the first part of the study, this first part of the study was partially supported by the US Air Force. We will like to keep going, doing some experiments. There are also facilities that are allowing to apply the big centrifuge for humans. So there are 3, at least in US, where we are trying to get access to them, because with this you can get the acceleration in more stable, easy condition for adding equipments and so on. But yes, the idea is trying to advance our studies by finding the proper circuit for increasing the G. But we have not yet, we are now applying for the funding for the next round.
It's only 2 G.
Yeah, only 2.
Yeah.
And what are
And
the
Raphael,
G-
oh,
what are
Raphael?
hang on a sec. What are the G forces associated with the Artemis rocket program? In other words, the astronauts who are going straight up, what is their G force exposure?
9
The application potentially with NASA.
I have no idea, but I
9
yeah,
to 10.
Does anybody know?
9 to 10 G.
9 to 10.
9 to 10. So I think the 9-10 is the physiological limit.
More than that.
Like that.
Yeah, Raphael?
Yes.
They're not vertical.
Here, let's
Raphael,
You're on. Well, I'm going to slide sharing. So
can I ask a question, Raphael?
Sure.
Yeah, Raphael, that was a phenomenal talk. Can you hear me?
Yeah.
Yeah.
Yes.
Yeah, that was a wonderful talk. Really amazing stuff. Have you thought of going in the opposite direction to microgravity? Is there any interest in that? Because you could fly this in the vomit comet, as they call it.
Yes, it's very, very interesting. And actually, we did some, I started when I was young trying to set up a study for the zero-G flight, and did some zero-G flights, but then the Italian Space Agency ran out of money, so we were never able to run the full study, unfortunately. But we tried with this aircraft to do a couple of maneuver. You need to. The problem is that you need special aircraft for doing this, because the oil that is used by the engine is collected at the lower part. So you can do only 2-3 seconds. After that, the oil is not getting in the engine. The engine is breaking, and you.
Yeah. Well, I see Kim Priska's on, and he's done a lot of this stuff. What does he think about this?
Sorry?
Yeah, okay, I'll chime in. Raphael, lovely talk. Couple of questions. I mean, how confident are you that lung volume really didn't change? Because that's really based on an integrated flow thing. So did you do any expiratory maneuvers, something down to residual volume, which we know is much more resistant to change? Because it strikes me that at 2.4 G, you'd expect a bit of an FRC change.
Yeah. So this was actually also what was interested about it. So we did the test on ourselves, and there was only one subject that was changing FRC by about 150 ml, and it was me.
Okay.
So originally, I thought that it was because of wisdom, can be the correlation of that, but very likely is more related to my body size, my body type, and my BMI, which is much bigger than the other young students. So I think that there might be also an effect on how your chest, all the tissue that is. And but most of all my students, but you have seen the tracing. You see that you can really check this on all the maneuvers, and there is no significant change in the first.
Okay. So somebody asked about Artemis. The G loads on launch are not that high because of structural limits on the vehicle, about 3G. But remember, the main load comes on re-entry, but remember it's GX, so that's eyeballs in as opposed. Raphael is talking about GZ, which is eyeballs down.
Yes.
So you got to watch what vector you're talking about. So the re-entry loads, which are higher, although not 9G, I don't think, although getting up there, but they're GX plus GX primarily. And certainly you could fly this in parabolic flight. That would fit in very easily. And I mean, it's never easy to do it, but it's not that hard either. If you're doing it in a plane like that, which would be even harder. Be a sitter for 0G type stuff. And you get, the nice thing about that is you get periods of 0G, and you get some decent periods of about 1.8 positive G as well. So you can get 0, 1, and 2, if you will, simplistically.
Really neat stuff. So the reactance was changing with G, of course. And you said, or attributed it to maybe increasing heterogeneity periphery. But we actually, due to gravity, have an inherent, and what we sometimes forget about is the tissue elastance, and the source of alveolar size. And that changes from the top of the lung to the bottom of the lung due to gravity normally.
Yeah.
So we have an inherent heterogeneity of our elastic properties from the top to the bottom, where we have more ventilation at the bottom normally than at the top, just because of the slinky effect. It's already stretched at the top, and it's not so stretched at the bottom due to the gravity. But now you put blood in the bottom. So I wonder if you've made our mostly elastic part where we actually tidally breathe, like this is the part of the lung that actually is changing most in volume. Most of our ventilation is down there, then at the very top of the apex of the lung due to gravity. But now you've filled it with blood, or you put more blood at the bottom in a gradient manner, I think. So maybe you've stiffened the bottom, and what you're seeing in X is not necessarily heterogeneous left to right, but you stiffen everything. You've moved it all up, so that X is actually a change in natural heterogeneity, just moving it. See what I mean?
Yes. Just keep in mind that with this test, we didn't use the inflatable garment because of 2G zone.
I know.
But I totally agree that
but it's
if you change, and
still moving within the lung to the bottom.
I totally agree that the change. I mean, you have what we are expecting is there might be some the upper part of the lung that will be distending, the lower part will be more compressed, and the evidence of the development of the absorption at collectors is. I mean, they need to have some airway closure with high concentration oxygen in order to do that. So, I mean, from the data that have been published, we know that this is happening to pilots. It means that there should be some say, peripheral occlusion or narrowing happening. Otherwise, you cannot, you won't have such an evidence of.
In rats, when you change the pulmonary blood volume, you change the oscillatory mechanics.
Yes,
there's
that's
a nice
right.
paper on that. And
there will
which
be
makes me think, can you try the 0G student on ground?
Yes. This is also a very good idea. Yes, this could be a very nice test to do.
Yeah, there's also a Blue Journal paper using shock pants to lung mechanics as well. There's some shock pants stuff from folks in France. But
so I'll also
the question I had, if you don't mind for a minute, Ken.
Sure.
Another possibility is change in respiratory muscle recruitment. So we showed years ago in pressure gradients in the esophagus, you can flip them in some subject by going to a rib cage predominant diaphragmatic versus a diaphragmatic abdominal. And I could imagine as you're making these sharp turns, the subjects are really kind of tensing up their chest wall or changing how they.
Well, I mean, the contribution of the muscles is something that should be evaluated. as a personal feeling, so the maneuver is done by moving the first phase is having the aircraft going on a 60 degrees inclination, and then you do the turn. So this the feeling you never feel a lateral acceleration. It's always cranio-caudal because the orientation of the aircraft. So it's something that, but you don't feel. I mean, 2G is you get twice as heavy, but it's not that bad to manage.
Anxiety,
Yeah.
but- So if you, since you're doing multiple of these,
Yeah.
how reproducible is it?
Very reproducible. So there we got extremely extremely.
So my idea.
Yeah.
I think you had a comment.
If I can chime in again, if I may, a couple of things come to mind. Dependent airway closure starts to loom, especially, and you're only at 2.4, but it's probably starting to kick off. And one of the reasons perhaps that Raphael's data look a little different to somebody else's, he's got a couple more years on his students. And your lungs do get old and floppy, I'm sorry. And so there may well be an age-dependent effect. And then the other thing is how much, if there is dependent airways closure going on, which may not necessarily be prevented a little by blood translocation into the lower limbs, but nevertheless you've got a bit of a compressive effect. And the third thing is the comment that you're pretty relaxed. It's really hard to be relaxed in changing G. Certainly the first few times you hit it. I mean, Ludwig Engel and Manuel Paiva did some respiratory inductance plethysmography measurements in parabolic flight. God, when was it? In the 90s anyway, which published in JAP, looking at chest wall mechanics. And they certainly change a little bit, and it's worth sort of keeping that in mind.
Yeah.
That's all I've got to say. It's lovely talk, Raphael.
Okay, so one more really scintillating. You guys have been talking. So let's get Brad.
Have you thought about a rat on your test center?
You don't have to answer that.
No, I think that our IRB will be more happy to have humans than. So I think that will be challenging.
The late Joran Hedensteer has he did EIT experiments in a centrifuge at south of Paris.
Yes,
that used to train these fighter pilots. So to dig out those data and see what.
Yes, there are few.
Bunch of rats in the center.
Humans.
Okay.
That's going to be my comment. There is a publication that came out a few years ago from Netherlands in collaboration with the Air Force here in Canada, and they actually saw improvements after being in the spinner in reactants, if I remember correctly. And I wonder what that was about. But of course, then they stayed much higher Gs for a longer period of time. Maybe they just empty themselves for blood, and that is going to have an effect on blood.
But all the measurements were done after.
And they were done after. Exactly. They spun and then they stopped.
Yes. And there are some other studies also showing this. The problem with DIT is that when you have blood displacement, also the measurement is more difficult to interpret because you have the reaction, but you also have the emptying of the conducting of you. So I think that
Raphael, thank you so much.
Okay, so we have an hour for lunch. It should be upstairs on the 6th floor if everything went as planned. We're back here for 3 more talks, plus a surprise talk. Stay tuned.
That's why we thank you.